again, thank you very, very much to those of you who've been able to join us. I know we have some commissioners in the room and some of us joining online, as well as many of our work group members and members of the public. Thank you very much for taking the time to join this meeting. We also are very grateful for our hosts, Prince George's County Government and the Prince George's County Health Department. Thank you very much to their whole team who put together the facility and the refreshments and so forth here in Prince George's County. We really appreciate the use of this facility. Dr. Matthew Levy isn't here just yet, but I do want to welcome Dr. Matthew Levy as one of our commissioners. He's Prince George's County Health Officer and was recently formally appointed by the governor to the commission to represent the local health officer urban position on our commission. So thank you, Dr. Levy, for participating as the commissioner. I also want to recognize the many members of our support team who are working really on a daily basis to keep the commission operating and running smoothly alongside some of our key organizations as well who are supporting the commission. And I'll introduce to start Shane Hatchett, who is the manager of the commission. He's going to do a roll call, but before we get to that, Chidabam Agbaluche, who is a doctoral student at Morgan State University and has been with the commission since the beginning as our support team, and Michelle Kahn, who is handling the mic and the slides and so forth from University of Maryland, and I think that was for our support team that's in the room. It's actually Jonathan Mespen, who is new to our commission and supporting us in our commission as a PhD student from University of Maryland. So thank you, all of those members of our our co-chairs for the commission, Dr. Tosin Olateju, who is the co-chair representing an HBCU on the commission. Dr. Boris Lushniak, who is the co-chair representing a state academic institution of public health. Thank you both as well for being here. And we'll introduce our speakers when we get to their time at that point. And again, thank you for all the commissioners joining us. Shane, would you be ready for a roll call? All right, great. Shane's going to take a roll call and make sure we have quorum.
Great. When I call your name, please respond with here or present, especially if you're online. Delegate Heather Bagnall. Camille Blakefall.
Present.
Christopher Brandt. Dr. Brewster. Jean Drummond. Senator Lamb.
I'm here.
Dr. Levy. Alyssa Lord. Dr. Lushniak.
I'm here, thank you.
Dr. Nilesh Kalyanaraman.
I'm here.
Dr. Olateju.
I'm here.
Fran Phillips.
Here.
Dr. Maura Rossman. Dr. Nicole Rochester. Michelle Spencer. Mr. Alan Twait.
Here.
We have quorum, and I'm sure we'll have a few additional commissioners joining us online in a little bit. And hopefully, Michelle, if you see any of our commissioners join, if you would mind to let Shane know.
Jean Drummond just joined.
Jean Drummond. Okay, welcome. Jean, thank you for joining us. All right, we're going to move forward, and I ask for a motion to adopt the agenda that was distributed in advance to our commissioners. Everyone is in agreement? Second. Thank you. All in favor of adopting the agenda plan for today's meeting?
Aye.
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 Michelle, are you able to? Okay, great. Does anybody need, if there's any days, please just not loud because we can't see you. Michelle can see you, but I'm not able to see. All right, and then also distributed in advance were the minutes from the prior commission meeting. October. If anybody wants to make a motion to approve those minutes, and then include the discussion, and then we can proceed.
So moved.
Second.
Second.
Great, thank you. Any discussion on the minutes or need for amendment? Hearing none, if everybody is interested in supporting the minutes prior to moving to my aye out loud.
Aye.
Aye.
Oh, they've seen the right one?
If any
This one is
nays
not
or
right.
abstentions,
Oh, you're projecting this one. You're projecting.
we're going to now move
Roll call.
to
This one.
actually before, thank you. Now that we've done the official business, I just want to recognize that this was a pretty monumental week for our country. Of course, anytime there's a presidential election,
Close this.
and it's a moment of great significance to our country. And as members of this commission, who are very focused on the landscape of public health in Maryland, we also need to be mindful of the landscape of public health nationally. Because certainly what's happening nationally with our federal public health leaders, with federal funding, with federal or national level policy can have a significant impact on the way public health is delivered here in Maryland. Of course, regardless of whether you're looking at the new administration with a sense of renewed hope, or if you're looking at it with some anxiety, or if you're more neutral in sentiment, I think it's really important that we as a commission stay tuned into what's happening nationally, what evolves nationally in the public health landscape, and consider how that might be impacting the delivery of public health services here in Maryland, or could impact the delivery of public health services here in Maryland. And we'll certainly, as a commission, bring updates to the commissioners. Significant changes happen nationally that might be influencing the delivery of public health services here. So that
Hello, thank you for that. I'd also just like to say that we're hearing like 2 or so conversations going on while you're speaking. And it's a little bit hard for us to kind of decipher what you're saying. So I'm not sure if it's people that are close to the computer or not, but we're getting that feedback.
Thank you so much for letting us know. I think it's our support team trying to troubleshoot some of the mechanics, so they're right up next to the laptop. But thanks for letting us know.
Thank you.
All right, I'm going to pass it over to Dr. Lushniak. He's going to introduce our first presenter. We're just really excited with our guest today in the commission. And is everything going okay there, Michelle?
They're just not synced up. Sorry for
Okay.
the
We're going to
interruption.
wait a minute for the slides to get synced up for those of you online, and Dr.
Just a
Lushniak.
question, so that, is it any better now? That we are,
Yes, it is. Thank you.
right, great. Please do let us know online. It's my pleasure here today as both co-chair as well as the dean of the School of Public Health at the University of Maryland, because the next speaker, Dr. Roderick King, is also an adjunct faculty member of the School of Public Health. So it's a pleasure seeing you here today, Roderick. He joined the University of Maryland Medical System to serve as the system's first ever senior vice president and chief equity, diversity, and inclusion officer, basically working across the system to develop a long-term roadmap for equity, diversity, inclusion that aligns with the system's strategic plan. He told me to keep his bio brief. We all have a copy of it. I don't want to use up his time. So therefore, I will use bullet points. I love bullet points that emphasize them. And what I'm going to say about him, you're going to be is so intrigued that you're actually going to read his bio. You know, some people's bio is just fluff. But when I give you the background to all this, so I'm going to say these words: pediatrician, senior associate dean, associate professor, adjunct professor, minority health policy, regional director, HRSA, health policy advisor to Senator Obama, commander, U.S. Public Health Service, my former service. So if you aren't already intrigued, if you think that you just met the most interesting person around, you have. I'm proud to present to our commission, Dr. Roderick K. King.
Thank you.
And I'm just I'd just like to thank, Chris, who actually introduced Dr. King to us
I'm
and
trying to.
suggested that he would be a good fit to come.
Yes, Dr. King, thank you for presenting for the hospital board at St. Joe, where I serve. So St. Joe is part of the University of Maryland Medical System. It's, I think, the only 5-star hospital in the state. Fran, presenting on I think it was the biggest focus, which got me very excited. And it seems like his work in the largest delivery system, and those, sort of one of the largest employers in the state, very much overlaps with the public health apparatus. Okay. Very excited.
Yes. I just like to just second and ditto everything that Chris said. And we're fortunate at Baltimore Washington Medical Center, also part of the system, to hear Dr. King present. I think the same reaction. Like, wow, this is very, very exciting, particularly in this context, as well as that one where we're trying to look at a diagram where population health and public health intersect and how we can move in that intersection.
Great. Well, thank you both. Truly an honor and privilege to be here. Good to see you, Fran. And I do have a little bit of a more of a tilt toward BWMC since I'm on the board of BWMC. But clearly we're all part of the UMS family. So thank you, Chris, for the invitation. And thank you, Dr. Wozniak. That's probably the best introduction I think I've ever had. And doesn't surprise me at all, of course. So thank you for that. All right. So what I wanted to do, Dr. Brewster told me that I had about an hour, but I don't want to take a whole hour because I'm going to flip through a number of different slides. But really to share with you how we've been approaching this work, specifically around equity in patient care at the University of Maryland Medical System. I will share with you at the beginning that it's a little different than probably what you've seen before, but that's intentional. But all of the current approach and some of the progress that we've made has been a culmination of the different roles and experiences that I've had in the past. It is nice to be back to speak to public health folks. As the former CEO of the Florida Public Health Institute, I kind of missed public health before I came here. And when I stepped into medical or hospital administration, I kind of had to pause a little bit and say, okay, is this what I want to do? But it's been a great ride, and I've brought all of my public health experience and knowledge to help guide some of this work through the system. So with that, let me jump right in. And for those that have seen the presentation before, you're going to see it's going to look a little duplicative. So you give me some grace on that, because I know there's folks that have seen this before. But hopefully there's a few things that are in there that are new that you have not seen. Because we have things even from last Friday. Some of the most recent health equity transformation event that we had around severe maternal morbidity. So let me jump right in. So what I'm hoping to do is give you a high-level overview of sort of the history of our journey on driving this work. And it's not a very long history. Talk specifically around the health equity transformation work within the area or body or strategic priority of what we call equity in patient care. Give you a sense of where we're trying to go with all of this. And if you don't mind, I'd like to sort of offer some insights as to why we haven't really made much progress around addressing health inequalities, or what we used to call health disparities back in the day. And then really wanted to have a conversation with you to see how we can better partner with public health in this. Talking to Dr. Brewster, and I was talking to Brent, the work can't be done by one institution. It truly has to be done by multiple partners. When I say the work, meaning improving the health of Marylanders, And the hospitals, health systems are just one part of that puzzle. And from my perspective, the other big part is public health. So we just have to begin to figure out what that looks like. So I'm going to share all this with you, and then hopefully it'll spark some ideas and conversations, and we'll go from there. So first, around the equity, diversity, inclusion journey for UMS. So historically, it's not a long journey. It started only in 2019 with the arrival of Dr. Sunza. And I think most folks know Dr. Sunza. When he first came, he was originally the CEO of the medical center and then became the CEO of the health system. But at that time, Dr. Sunza made it a point that he wanted equity, diversity, inclusion to be a cornerstone of the transformation of the system. Essentially, up to this point, the hospitals, although they were all part of UMS, didn't really fully gel as a system. And so he was on this journey to try to figure out how do we move forward with becoming more system-like. And with that, he wanted equity and diversity inclusion to be a cornerstone of that. So just flip through some of the others, which you could read for yourself. Once he sort of made that statement, he gathered leaders across the system, began to think about what should be the work streams, what we now call our strategic priorities. Presented it to the board supported it, they allocated some resources to guide it. Then they started looking for my role in November of 21, and then I signed on in April of November 20, and then I signed on in April of 21, and then started officially in July of 2021, which was, as you guys remember, right in the middle of COVID. So it was an interesting time to stand up this work at the time. Folks will often say, well, great, what's your team like? And I said, well, the team was just me at the time. And we were trying to figure out how to build this work and then obviously think through who were the people and the skills we needed on board. And then had the honor and privilege to bring on Dr. Tiffany Wiggins, who I think some of you have met, who is our new Chief Health Equity Officer. She follows in the heels of Dr. Joseph Wright, who you guys probably know, Dr. Wright, who was our inaugural Chief Health Equity Officer, who came on shortly after I came. So that's our history. But before I jump into it, my little spoiler alert is that our approach is a little different. And the reason that it's different is that it's based on this concept of system transformation, right? It's not based on a program. It's not based on a specific disparity. It's based on this idea of how do you change the way the system works to be able to identify the problems around health disparities and then drive the work across the whole system together around improving those outcomes. And so I bring that up because it really is not the typical way that folks have looked at this body of work, right? So I know this is one of Fran's favorites, the systems change. We've talked many times about it. For folks that don't know, this comes from the resource from Kanye Kramer and Peter Drucker around how do you change a system. And the reason that we're approaching it from a systems change approach is that systems change is required, or it's about shifting the conditions that are holding the problem in place. So what it implies is that it's not just, oh, are the diabetics getting their screenings? Are the diabetics getting their neurological checks? It's more so what are everything that's happening both within the system and the community that's causing or prohibiting the patient from being able to manage their diabetes. And so you think about that as an entire system. Right? So on that, what I did to add to that was then say, okay, well, if we're looking for system change, what's the steps toward it? And so years ago, Joe Betancourt, some of you may know Joe from one of the original authors of the Unequal Treatment Report. Joe and I are classmates. We started the Disparity Solution Center, and one of the things that we started was the signature program called the Disparities Leadership Program. And we tried to pilot this idea of using John Cotter's model around leading change to see if it would help hospitals, health plans, and community-based organizations lead their change effort around addressing a health inequality. And we found that it worked, particularly around organizational change. And what it did prove for us is that the work isn't just a clinical issue, it's actually a change of the entire organization, right? That you have to be able to think about. And folks have to develop that capacity to lead through that change. And so what the rest of the work is built on is those two pieces. Now, building on that, just talking more about, if you think about it from systems transformation, Dr. Sensen and I from the get-go began to think through, okay, how do we begin to build this and what I call into the DNA of the system, right? It's not a program, it's not an offshoot from quality, it's not an offshoot from Marcoms or any clinical ops, right? It's actually in the DNA of the system. And so one of the things we did is we made equity, diversity, inclusion a shared service. So folks that don't know, I didn't know until I came to the hospital. Within a hospital system, they group together or centralize a body of services that serves all the hospitals, and they call them shared services. So for example, finance might be a shared service, and this sits within corporate, but it helps the financial operations for all the hospitals. Marcoms is a shared service. Legal is a shared service, et cetera, right? But this was the first time that any system had made equity and diversity inclusion a shared service. So we built it as a shared service to be able to serve and operate and support all the hospitals that were going to drive the work around equity, diversity, inclusion. On the heels of that, what had been done just before I came, was that the leaders within the system had already developed what at that time was called work streams, but now we call them functional areas to align with our strategic plan. But these were the 4 ways that they thought we could operationalize the work of EDI. And just to kind of name for folks, one of the challenges of driving this work in healthcare is that we've gotten really good at describing the problems. We know how well the disparities are, where they are, how big they are. We've gotten really good at studying them and even trying a few things. But what we haven't been great at is trying to take the studies and the research and then operationalize it within a healthcare setting. And so the idea was these were going to be the 4 strategic areas: equity and patient care, diversity, inclusion in the workforce, community health impact, and external partners. The one other thing that I'll name is that typically, if you look at folks in my role, now, the truth is my role varies from hospital to hospital based on where you are in the country. But if you look at someone in my role, usually this work sits under either the quality team, or in some places, I think at Hopkins, it sits under HR, right? This is the first time that I have seen, and this is one of the reasons that Dr. Swinton and I talked about it, where I report directly to the CEO. And all these areas of work, which tend to be typically sit in other different parts of the organization, all are under myself and Dr. Swinton. Now, with that, what we did is we built a structure, a governance structure, to ensure that, as I often would tell folks, that this wasn't all a Dr. King show, right? So if we're looking at equity, for example, workforce diversity inclusion, the head of HR, our CHRO, and myself lead that together. When we look at equity and patient care, Dr. Wiggins and I together lead that. So I show this because it's what we call in the leadership world a collaborative leadership model, right? Where it's not one person that's accountable, but it's the 2 heads of the operational areas that drive this work together. And it helps to, again, build this work into the DNA of how we do this every day. So what I'm going to do is now pivot and talk more about equity and patient care specifically, and show you very quickly, but you guys have the slides so you can take some more time to go through it, but just at a high level of how and why we've been driving this work across the system. So first, what I had to do was begin the conversations with some of the leaders that equity is not a new concept. The folks that are familiar with the literature know that back in 1999 and then 2001, what we called back then the Institute of Medicine, Boris will remember before they renamed it as the National Academy, and also Dr. Rochester. These were the seminal reports that basically said that quality was an issue in healthcare. Right. The first one was To Err Is Human. The second one was this one, Crossing the Quality Chasm in 2001. On the heels of this, 2 years later, a third report called Unequal Treatment, and this is the one that Dr. Betancourt was instrumental in helping to author, as well as a very broad committee, basically say health disparities do exist in the United States. Believe it or not, there was still a lot of debate up until that point. The report kind of was the line in the sand. But the thing that I wanted to share with my colleagues is the original quality report in 2001 had clearly laid out that there were 6 pillars to quality. Right? You can read them there: safety, safe care, effective care, patient-centered, timely, efficient, and equitable. Right? But the interesting part that I tell my colleagues is that over the next 20 years, the equitable part has kind of faded away. You hear lots of conversations around safe and effective care, patient-centered care, efficient care. You don't hear much about equity. So the way that Dr. Sunta and I, now Dr. Pollack, our Chief Clinical Officer, we tell folks we're putting equity back into quality. Right? This is where it always has been, but we have not advanced it as a system to show how the connection exists. Okay. So under equity and patient care, there are 2 big buckets of work. And I'm going to go through these very quickly. But again, you guys can look at the slides. The first is what we had called race-based clinical algorithms and technologies. In short, this is the body of work that we started shortly after I came with Dr. Wright to look at clinical algorithms that inappropriately, without really research-based, embed race or race as a factor in assessing or determining clinical care and clinical care strategies, right? That's in a very simple way. These algorithms exist all throughout medicine. One of the more common questions folks ask is, well, how many are there, Dr. Kane? I was like, I really don't know, because, you know, Boris and Dr. Rogers, all of us learned these things, and we never actually knew that there was no real research that these racial factors were included. But now the research over the past decade or so has shown that there is no reason to include race, because race is a social factor. It's not a biological factor. So what we have taken on is to slowly begin to remove those out of clinical care. Now, if you ever had to change clinical algorithms, probably the only thing harder than that is changing a medical education curriculum, and then probably maybe public health curriculum. Is not easy, and it's a long timeline. But we started that work in 2001, and we continued. So you can see here, the first ones we started with the removal of race from eGFR, what we call estimated glomerular filtration rate, which essentially is one of the key factors to assess whether a patient is eligible for a kidney transplant or not. We modified the VBAC, or what we call vaginal birth after C-section calculator, and the one that Dr. Wiggins is now taking on is the PFTs. And we don't have time to get into it, but if you all are interested, I would encourage you to start to dig into some of the history of how race got included in some of these factors, and it is fascinating. And again, no scientific basis, but it does go back to sort of a cultural, historical mindset that happened, and then they included race in those factors. The next body of work, oh, this is to highlight, these are some of the pieces that we've done around those race-based clinical algorithms. But one of the things that folks will ask me is, okay, Dr. King, you guys removed race from eGFR. Have you seen any impact? Now, one of the challenges is when you do these types of bodies of work, there's a very long timeline before you start to see some impact on communities and lives of patients. However, we got a little glimpse of this into what might be the impact around eGFR. So earlier this year, there was a study that was put out by the AP that showed, I forget the kidney transplantation group, but they went back and recalculated GFRs for all the patients with the removal of race. And what they found was that 14,000 Black patients were now eligible for kidney transplantation. Now, you take that and you superimpose on top of that, that the University of Maryland Medical Center is the #1 transplantation site for African-American patients in the country. So you put those two together. I know it's not true causality, so don't hold me to that, Boris, but there is association that with removal of this, we will have dramatic impact on the lives of Americans, particularly African-Americans that were not eligible, but now are eligible for kidney transplantation. So we are starting to get a little glimpse that this will have significant impact. And you're starting to see more pieces on this body of work also. The last one, just to finish off the race-based clinical algorithms, is around pulse oximetry. You guys have probably heard most of this, so I won't belabor it, but in short, as you know, the pulse ox does not work for darker skinned patients, just in a very layperson's way. So we're now trying to figure out how do we mitigate this risk, and how do we think through either replacing the pulse ox machines, whether we change the way the pulse ox machines are used, et cetera, et cetera. And the FDA has been under a lot of pressure from both the federal government, executive arm, as well as the state attorney generals. They signed a national letter together to say that they expect the FDA to do something about pulse oxes immediately, including our own AG, Anthony Brown in Maryland. So this is probably more work that's going to gain more attention as we move forward around this. So let me get to really the bulk of what we were going to talk about. So the health equity transformation work. So when I came, as I mentioned, we were in the middle of COVID. So hard to get everyone garnered, but that was okay, because I realized one of the cornerstone pieces of driving this work from the systems change perspective is you had to have a very strong data foundation to make the case. Right? As I tell folks sometimes, believe it or not, I still had to convince folks that we had disparities at the University of Maryland medical systems. Folks still challenge the data and said, "Are you sure, Dr. King?" And I'm like, "Yeah, trust me, we have disparities there." And so I spent pretty much the first 6 to 8 months digging into identifying a core set of what I call health equity metrics. And we don't have time to get into the specifics of it, but believe it or not, this took an enormous amount of work. Why? Because the enterprise and data analytics team didn't talk to the quality business intelligence team, and they didn't talk to the finance data team. And they all had to be part of this conversation. So literally, I had weekly calls with them. We introduced each other and said, hey, you guys get to know each other, even though we all work for the same system. And then I challenged them to say, guys, we got to come up with a handful of metrics to be able to tell us if we're making measurable progress on addressing health inequalities within the system. So on the bottom, it's hard to see because it's a little covered up. Sorry about that. But on the bottom right, you see the selection criteria that I told them was, look, we only wanted a handful of metrics, not 25. Making sure that the data was available, making sure that these factors were visible and people understood. And then finally, making sure that there were proxies for other things. And what we mean by that is, for example, if you're making measurable progress, for example, on, say, hypertension or diabetes, more likely than not, all the other disparities are going to head in the same direction too. So those two become a proxy for other cardiovascular things that you may see, right? The reason that's important and why we didn't want a lot is I give the metaphor for folks that in order for a system to move forward and focus, you only need a couple of dials. So the comparison I give is when you hop into your car. When you jump into your car, you do not have 20 dials on your dashboard. Right? You have probably 4, and most of us pay attention to 2. How fast you're going, so you don't get a ticket, or whether you got gas. That's pretty much it, right? That's because those are the things that we need to focus on in order to make sure we get to where we're going and making sure that we can get there safely. Same thing here, 5 to 8 for the entire system. We put them in these buckets, what I call high profile. So these are metrics that people knew and heard about in the news, things like maternal mortality, opioid dosing, really, not really opioid use because there's a difference, which is more population health measure. I then asked the data folks to talk about what were leading diseases across the system. So these are the top leading diseases. So it probably matches every other hospital in the state, right? So diabetes, hypertension, congestive heart failure. And then I said, what are those things are where there's high utilization or what we call cost drivers? Right? So pediatric ED visits, so pediatric visits going in and out the ED, and unplanned readmissions. The other takeaway on this is you see some of them have a little red star. That little red star is because Dr. Gourdine, who I think most of you probably know, who was once a former deputy secretary, Dr. Gourdine was the chief medical officer and the chief population health officer at the time. And so Michelle and I were thinking through this, and I said, you know, Michelle, it's probably really important that we tie these health equity metrics to population health metrics so that there isn't a separate public health strategy and a separate equity strategy. And she said, yes. So those little stars are SIHIS measures. They're the same ones. And that was done with intention to tie together the population health strategy with the health equity strategy. So with this has been our guiding stars, right? This is where we've been driving the work. This is how we're building capacity within the hospitals. And then I'll talk to you a little about how we sort of made it easily accessible for the team members across the system. All right. As part of this data analytics, although it sounded fairly straightforward, I said, let's also share with our team members the demographics of our patient population. Even though folks kind of knew what the general racial demographics are, but when you put it in this context, although the format's a little off, so sorry about that, you see that for the overall for the system, we're about 50% the patients declare themselves self-identify as Black African Americans. So we're about half. If you add in the Latino Hispanic population, we have a very small Native American, we're over 50%, right? But the bars at the bottom show you the variability of the demographics from hospital to hospital. Now, I put it up there for them to see, not to say that one is better than the other, but to show that if we're going to, each hospital is going to develop a health equity plan, it's got to be their health equity plan. I cannot write a health equity plan from the corporate office that fits the demographics of every hospital because it varies too much, right? And so although we'll have a similar way of approaching it, everybody's going to have to customize it a little bit for their patient population. We added on the ethnicity category also to just show that we do have a fairly rapidly increasing Hispanic Latino population across the state, particularly on the shore. And then the other piece is we started looking at some of the rural health aspects, right? Particularly since we have a hospital on the Eastern Shore, and what's that interplay between some of the interplay between what's the some of the health equity disparities and things that are contributing from a rural health perspective, for example. So we took all that data, packaged it all up, shared it with Dr. Santa, and then began to show what it looked like across the system. So it's a little hard to see, but the data on the right just basically says, yes, we have disparities, particularly around severe maternal morbidity. We also had disparities on C-section rates. And then it's hard to tell, but when you look at the data, each grouping is one of the hospitals. And each bar represents a racial ethnic category. So the point was not necessarily to compare one hospital to the other. The point was to kind of show where you're starting. And that black line is again, it's covered up, is the state average, right? That's the state target around severe maternal morbidity. And you can see most of the hospitals are above it. Right? So once we took all this data and we demonstrated and made the case that yes, disparities do exist, and we share with them that we need to think about rural health in the context of how that interplay is happening, then we went to the next phase of then putting it all in a dashboard. We built this massive dashboard that has every one of those metrics that you saw broken out by race, ethnicity, gender. And it's hard to see, but this is the one for diabetes and pre-diabetes. But there are options to click on the tab so you can see what BWMC looks like. You can see what St. Joe's looks like. You can see what Charles looks like. And again, not to compare, but just to see what's going on. And this allows them to get a sense of the overview of who is being diagnosed with diabetes across the system, what disparities are we seeing, and then also how do they compare time over time. Okay, so this now gives them not just the 8 metrics, but now they can go in and tinker with it. They can play with it, they can look at it and go, oh, okay. So this is where folks came back to me and said, well, you know, Dr. King, we don't have disparities at our institution. I was like, oh, really? I was like, okay, let's go back. We went back, and they still do. But again, it brought everybody on the same page because, again, the data was the foundational piece of all of this. We had to get everybody to both understand and embrace where we were. So the last part was then, after I packaged all that data, Dr. Wright was still here with me at the time, is we then went on a roadshow. We went to every hospital. And we said, here's your data, guys. Went to all the C-suites. I said, what do you guys think? And of course, everybody was like, oh my gosh, I can't believe that. Why is that happening? And I said, well, that's the next part of the work. And so what I did ask them when we did that, I said, I have one request, is I need your organization to pick one disparity, not all 8, just one. And of course, people ask, well, why is that? I said, because we're going to spend a year building the muscle, building the capacity on how to address that disparity, right? Because there's a misconception that, oh yeah, once you've identified, we know what to do. Actually, we don't really know what to do, and you don't do it in a systematic way. So the plan was to teach them. And so out of that, they picked, these are the ones that each hospital picked. And then we launched what we call the Health Equity Challenge. We gave them 90 days, actually a little bit more, but 90 days to develop a health equity plan for the metric they identified. Right? Of course, folks started off and said, oh my gosh, Dr. King, we can't do that. You know, we got COVID, we got this. I was like, okay, got it. We're going to help you. So I brought in some consultants to help us, to help support some of the facilitated conversations. But then we jumped right into the work. Now, here's what the work started to look like. So now this is a year ago. It's hard to believe it's a year. October of 23. And I brought in my dear friend, Deidre Epps, who runs Race for Equity. And she and I actually worked in Baltimore around early education back in the early 2000s. And so she was gracious enough to bring her team to help facilitate it because, as you can imagine, we got 8 hospitals, teams of about 10, sometimes 15 people per hospital. And we had to help them learn the approach, the model, and help them facilitate to have the conversations to apply the model. Clearly much more work than I could do, but with Deidre's help and her team, it was a great success. So with that, we kept going. I just wanted to share, sorry, the formatting got shifted somehow. Share that this is the model that we're using. It's called, from the book called Trying Hard Is Not Good Enough from Mark Friedman. I don't know if you guys remember Mark from back in the early 2000s, late 90s. This actually comes from the Casey Foundation. And that's how I first learned about it. It's a simple way. It's very similar to like a PDSA cycle and all the others that you guys know, but it's a very simplistic way. But the part about that really helps bring together community leaders is that it's grounded in understanding what's the root cause. Right? Oftentimes when we're talking about health disparity, we don't really know what's causing it. We have assumptions, we have guesses, but we don't know necessarily for that particular patient population. So this is the model we used. It was first used, as I said, in the early 2000s in Maryland around early education, where they saw a dramatic increase in children ready to learn from 2002 to 2012. And so I was part of that group. I just left the Fed. I was part of that group. They brought me as a pediatrician, and I said, hey guys, had you guys thought about applying this to a public health issue? I said, we started thinking about this. And in fact, someone approached us about doing this around infant mortality in Baltimore. Fran knows this. Fran was part of the original group. Thank you, Fran. Yes, and we did it. And it was called, the Casey Foundation called it Babies Born Healthy. So that was the Leadership in Action program. Most folks don't know that anymore, Fran. That's a little sad for me. But what they do know is what it's Be More for Healthy Babies. So if you guys know Be More for Healthy Babies, how they've been able to reduce infant mortality in the city, first time ever. They increased infant mortality by 40%, the disparity by more than 50%, and teen birth weights have dropped by 44%. As far as I know, this is one of the few examples where we actually got rid of a disparity gap around a public health issue. So using this insight, I started thinking, okay, where else can we try it? So I've tried the model, I've used the model in multiple different places. We used it in Miami, where we're trying to address the issue of violence over town in South Miami. I used it with a team in Savannah, where they were trying to tackle the issue of poverty, and in multiple different cities. And it's a very effective and very powerful group. And so, Fran, you probably remember the picture. I was a lot skinnier and younger back then. Yes. But that was the team, myself and Vicki Goddard Truitt, who was a pediatric nurse. Two of us led the group to these results. And then it was transitioned to the Baltimore City Health Department. And that's where it got rebranded as Be More for Healthy Babies. So that's how I know Josh. Josh was the commissioner for the Baltimore City Health Department at the time. What's that? Yes, he is too. So this is the model. So as I told you, it's that simple circle, but this is just with it laying out. And it just lays out what we call turn to curve thinking. How are we doing? So those trend lines that they got, what's the story behind the curve? Again, pushing them to think through what's causing the disparity. Who are the partners to help? What works? Are there examples of people that have tried to tackle this before, and what have they done? And then what's your plan with a budget? And then the piece that we added is we asked, as each member org developed their plan and their strategies, to develop KPIs for each strategy that they did. The reason is that we often in healthcare, I'll say in general, is we get enamored with a beautiful strategy, methodology. We spend 2 years planning it, blah, blah, blah. We put it in place, and then sometimes we don't know if it works or not. Right? But it looked good when we built it and put it together and applied to NIH. This will tell us in 6 months if you're making progress. If you're not making progress, the charge to the group is you got to go back up to the top to the same circle of migrant and figure out, do you have the right root cause? Do you have the right story? Did you miss something? If there's something else going on, let's say around severe maternal morbidity, that you missed the first time. So it's an iterative process to go round and round to be able to get to the point of having root causes, strategies that align with those root causes, KPIs, and then seeing if you're making a measurable difference. I'll say why. Now, this is the part that I often tell folks that this is the hardest part of this work, particularly in the hospital sector. So you can imagine getting together 150 hospital people, and you say to them, well, what's the cause of severe maternal morbidity? Everybody goes, it's anemia. And I'm like, okay, yes, I know they presented with anemia, but what's going on? Why are they anemic? Now they have to think outside the boundary of the hospital. What's going on for that mom? Did she have prenatal care or not? Is she eating appropriately or not? What's the different factors? And so this was the stretch, because in that story behind the curve, what's going on, I've pushed them to be able to get information from patients, from providers. They're welcome to get more information from DHR, but they had to also get information from community partners, population health, public health partners, as well as faith-based partners. So in other words, they had to go out and ask the moms what happened. This is a stretch, I'll be honest, for the healthcare sector, because we're normally used to operating within the confines of when a patient comes through the door and when they go out the door. That's pretty much it. So now in hindsight, when you've asked them a year later, in fact, I got some really nice validation last week. A couple of providers came to me and they said, Dr. King, we got it. We get it now. I was like, good. So this is the part of the work of trying to identify the root cause. And then this is the trend lines. So those same metrics that I showed you, what we did is we took that data and we made trend lines quarter over quarter over the last 2 years. So they can see what the two lines are. So let's see. So the blue line is non-Hispanic white, and the green line is non-Hispanic black. Okay. Now you may say, well, Dr. King, why do you do this? We did this because you give the team this information to understand what it looked like over the past 4 years. But more specifically, you give them a sense of what's the goal, right? So they got a target they're aiming for. But what I would also argue, which is very powerful, is you also give them a sense, that bracket is off, of what that gap is. And we often talk about disparities, and it's a normal statistical issue. We'll talk about it in terms of percent. We'll talk about it in a ratio, but we actually don't know how many patients that is. And so one of the things that I had the team do is to quantify it. So if you look at like SMM for this particular group, I think this is BWMC, Frank. Yeah. And you actually quantify it, you're probably looking at anywhere between 5 to 9 mothers. When you do that for a group, everyone goes, oh, we could do something about that. It now becomes doable, right? It's not this big number, it's not hundreds of moms. And they realize, okay, this is within our reach. So it's a strategy for helping them understand that this is a problem they can get their hands around, that they can reduce that gap. And it doesn't take much to get below the target line of the goal, where we're trying to go. Right? So every team that picked that disparity had this trend line, whether you did severe maternal morbidity, whether you did diabetes, whether you did unplanned readmissions, whether you did pediatric asthma. So they all knew how many patients they were talking about to try to reduce it. Okay? Yeah.
3 or 4 moms.
Yeah, 3 or 4 more a quarter. Yeah. So you're not talking dozens of women, right? But the whole idea is to get them in the mindset of shifting their model, that it's not a large number of people, finite, doable number of patients that they can impact. So this is just quick highlights. After they learned the model, they went back to the hospitals. They continued to drill down into, what were the factors, right? The story behind the curve. What are the factors that are driving this work? Just very quickly, they had to come up with, when they came up with their strategies or their actions, they had to come up with things that were immediate things that can do, short-term things, and things that would take them some while to implement. And then finally, once they came up with their strategy, immediate, short-term, and long, then they had to come up with key performance indicators that tell us how well did you do it, how much did you do, is anyone better off, right? So that's the framework. Now, what you'll notice that it's a very structured way, right? I didn't tell them to look for certain factors. I didn't tell them to address certain problems. I said, you guys figure out the problems, but I need you to do it this way. So what I mentioned to you earlier around capacity building, this is the capacity building. So now that they've gotten this under their belt and are like, okay, great. And they practiced it for a whole year. And then they went forward. We had a milestone event in March to present all of their health equity plans. Remember, we started in October and then they presented it in March. And then from there, we created a second dashboard to include all of their strategies and all their KPIs. Right? So if a hospital picked, for example, BWMC, picked severe maternal morbidity, they may have 3 or 4 strategies. Each of those strategies, they have KPIs to measure how much are they going to do, how well they're going to do it, and if anyone's better off based on that strategy. So it's the same structure that they're doing over and over and over again. So this is the capacity building. Now this helps us to hold accountability. Right? So one of the other issues, Fran will remember this from Babies Born Healthy, is we love accountability, right? Because one of the challenges for large groups is that you guys probably have this experience. You all come together, you have a great conversation, and we'll say, yeah, Roderick will do this, Fran will do that, Chris will do this, Boris will do that, and then you walk away and you come back to the next meeting and go, okay, anybody do anything? Like, we don't know, right? That's what we call a group not holding accountability for themselves. Right? So what we did is we built it into the dashboard. So everybody can go in. They can go look at BWI's progress. They can look at the medical center's progress. Everybody can look. There's no secrets around it. But what we're doing is we're normalizing accountability. Typically, accountability is a shame thing. Like, oh my gosh, I didn't get my homework done. It's horrible. Got it. No, we're saying, no. It's okay. Look, we all are busy. But if you're not able to get it done, let's figure out how we help each other do it together. It's one of the key steps to build toward what I call, what the literature calls shared accountability, right? Where we all hold each other accountable for the same work that we're driving forward. So quickly, let me just go through. One of the things that worked out great for us is, as some of you may know, Joint Commission last year rolled out their new accreditation requirements around health equity. The beauty is, and it was intentional, that by doing this work now, of the 6 areas on Joint Commission, every hospital now in the system can respond to 5. The reason they can't report to the 6 is because the 6 ask you to explain what you've done in the long term, and they just started the work, right? In addition, CMS, some of you may know, rolled out a attestation rule, basically saying that hospitals have to begin to think about developing health equity plans, and they have to be able to share it with their boards. So Fran knows this. We've talked to BWMC board and St. Joe's, et cetera. So the boards are now getting involved in hearing about this. So all of this we now have in place. And I think we're the only hospital in the system, probably in the country, that actually can do this for both the Joint Commission as well as for CMS. All right, so how do you make sure that all this stuff that I was doing will last, right? So God forbid something happened to me, how do you make sure that it keeps going? This is something that when you're thinking about this body of work, particularly around systems transformation, you have to build in from the beginning. So remember, Dr. Sunth and I created that collaborative leadership structure, right? So doing this with the CHRO, I'm doing this with the chief clinical officer, et cetera. The other things that we did was we had a diversity committee at the corporate board level. And this is one of the things I did during COVID, because I had the flexibility and they were interested. And I said, hey, Dr. Sunth, board chair, what if we take the diversity committee and I make it an EDI committee? Purpose of doing that is now there's a corporate board committee that holds the rest of the organization accountable for all that stuff I just showed you. Right? So there are board members that are watching this and going, hey guys, what are you doing around your health equity challenge? What are you doing around workforce diversity? What are you doing around your supply chain diversity? But it's at the corporate board level to hold that accountability. Right? The next thing we did, as I shared before, we made it a shared service. And now it's baked in just like all the other shared services, finance, legal, compliance and audit, so on and so on. Right? And then the other part, which we're actively doing now, is trying to bake it into the key strategic body of work around the system, whether it's the HRO journey. We don't have time on this, but this is a massive approach across the system around improving quality and safety across the system. But we're baking equity into that, whether it's our strategic framework or whether it's our HR, transforming our HR system. We want all these pieces to be integrated into the strategic planning. So again, it's part of the DNA of the system. All right. The last couple of pieces I'll share, a little more fun, is I've always, now I have the opportunity, wondered if there was a way that we can bake health equity into the financing mechanism. Now, for those of you that are policy wonks and know healthcare financing, typically hospitals or major changes in hospitals typically occur only when there's financial incentives tied to it. Quality movement, when CMS started to roll out quality metrics that hospitals had to report on, and then their reimbursements were tied to that. The one I used to tell my students when I was teaching years ago is when hospitals desegregated in 1964. And folks are like, well, why did hospitals all of a sudden start to desegregate? Because at that time, you had black waiting rooms and white waiting rooms, black doctors and white doctors. What drove hospitals to desegregate, and by the way, the AMA was not in support of it, was the passage of Medicaid and Medicare. And Johnson said, hey, if you want federal dollars, you have to desegregate your hospitals. And that's what catalyzed desegregation in healthcare. Right? So building on that, now we're at this critical junction. How do we begin to include metrics, financial incentives, tied to drive some of the work that I've showed you around equity and patient care? So over the past year and a half, worked with the finance team, BRG, the big consulting group. We started brainstorming about this. But I knew that the opportunity for the new model for Maryland was coming up. So we pitched this to Secretary Herrera-Scott last summer. Can't believe it's a whole summer. And say, hey, Laura, we think there's a way that we can modify the way that the financing for the state of Maryland through a total cost of care model to integrate health equity. Well, at the same time, CMS also rolled out that, hey, we want hospitals to consider this new AHEAD model. They never said Maryland, they just said AHEAD model. And then as momentum started to happen and they started lifting up the Maryland model, they said, you know, Maryland, we expect you to do the AHEAD model. And so some of the folks may know, last Friday was the historic event when the governor and all these fancy bigwigs signed the contract with CMS to implement the AHEAD model in Maryland. That was on Friday morning. Okay. So now we have the opportunity, to now bake in financial incentives to drive health equity across the state. This is groundbreaking stuff. No state that I know of has this. The closest thing is Blue Cross Blue Shield in Massachusetts rolled out a pay for equity program the beginning of 23. But they're one insurer of several within the state of Massachusetts. We have the global payment system. So this has never been done before. So we are now in the throes, now that the contract has been signed by the governor, of trying to figure out what does that mean, pay for equity? What does that look like? And so this is the part that's interesting of where we can find certain levers to connect healthcare to public health, to other areas to drive this work forward. Okay? Now, what I did want to do is share a little bit about why it's been hard to advance this work, but it also helps to explain why I built it the way we did at UMS. So if you guys will indulge me for a moment, a lot of this comes from some sort of musings of Dr. Betancourt and I, because we had the opportunity to work with probably well over 300 hospitals and health plans, all struggling with this over the past decade and a half. And there were a couple of key things that came out of some of my observations, right, from the Disparity Solution Center, if you guys know. So one of the first things is effective improvements around health disparities or health inequalities require systems change. That's what I was sharing with you before. There are things within our system, not just but any hospital system, that hold the problem in place, whether it's provider bias, whether it's inability for patients to navigate the system, whatever it might be, there's things in there that is causing and contributing to it. So you have to think about this work, not as a program, but as a way to change the system. Right? The second thing is oftentimes strategies and tactics are based on assumptions. You'll hear folks say like, yeah, we think the problem for moms is this, so we're going to implement this program. Not really based on data, not really a root cause analysis, probably a fair observation. But what we're trying to do is say, okay, that's good, but let's figure out what's driving it for our moms at Midtown, or what's driving it for our moms at Charles, or what's driving it for our moms on the Eastern Shore, right? Which leads to the third part. Oftentimes, if we don't know the root cause, we oversimplify the problem, right? So I've actually had some of my colleagues at Care First, I won't name anyone, that came to me and said, hey, we're looking for that one diabetes program that we can just scale and drive diabetes improvement across the state. And I said, guys, there is no such program, right? I said, because if you've seen a diabetic that's having trouble to control their sugar on the shore, that's different than the diabetic that's having problems in West Baltimore. And that's different than the diabetic up in Towson, right? So you have to think about it, not in a simplistic way of what's one program we can roll out and scale, but to think about it, how do we design it, learning from each other, because there might be some similarities, specific to the patient population that are there. And my hunch is that they're going to be similar kind of factors, but they're going to change slightly from place to place, right? So transportation might be a big issue on the shore, probably won't be a big issue in West Baltimore, but cost might be a big issue in West Baltimore, might be also an issue on the shore. So you'll find similar factors, but certain things will pop up as priorities more so that you have to address. The other thing is what I've now started calling about embracing the complexity, right? Which ties to oversimplification. We want sort of that magic answer. We want that one program, and there is no one program. And so the best way is to kind of figure out what's going on for our patient population, and then trying to understand what are the strategies we need to put in place for those specific patient populations. And then the last part is not making sure, oftentimes we don't have all the partners at the table. I always tease my clinical partners. It's that streetlight effect. You guys probably have seen the cartoon with the guy looking for his keys. Ever seen this animation? No? Okay. So the animation, there's a guy outside, there's a streetlight stands on the street, it's dark, and he's looking for his keys, and he's under the light. Police officer comes over and says, sir, what's going on? He says, I can't find my keys. And he says, oh, where'd you leave them? He says, over there in the dark. So he says, well, why are you looking here? Because this is where the light is, right? I call it the streetlight effect. In clinical medicine, we just look right where Epic shows us. They say, well, Epic said this. I said, yeah, but what's going on over there? What's happening before the mom comes? What's happening in these other sectors? So what we're trying to do is to make sure that we push our colleagues, and this is where all of you come in handy, or come in to help us with that, is understanding where the keys might be, not where the light is. That makes sense. Okay. All right. I won't spend a lot of time on this, but again, I encourage you guys to just pull up. It's one article around systems change. I think it's called The Waters of Change from Kramer, Kanye, and Senge. And then just actually go back to this. Just the highlight for this, what I tell folks is typically when driving this work, most of the time we focus on policy changes, practices, and resource flows, like where money goes. But the goal, or where you're trying to get to, is changing mental models. You're trying to get people to think differently about these patients, that not ascribe them to, oh, Mr. Jones or Mrs. Jones are non-compliant, or something's wrong, or the patient is poor. Like they're holding these mental models that are preventing them from understanding the dynamics of what patients are facing to be able to address the disparity. So the reason that's important is that these mental models, this is from Peter Senge, are deeply ingrained assumptions that we all have as human beings, but they drive how we understand the world and how we take action. So if you think all the issues are moms having one specific issue, and you're holding that, then all the strategies you develop will be based on that mental model. So we're trying to shift that mental model by having them dig into figuring out what really may be happening for these patients. So I've mentioned the difference in our approach, that we're not looking at it sort of as a program, but more around systems change and using the systems change model. What I wanted to then sort of end with is this concept, or at least some ideas on where we might be able to partner. Now, you may notice when I talked about the root cause analysis, that one of the key partners is population and public health, right? We may know what happens when the patient walks through the door, but we don't know what's happening in the community, right? So this idea of how we can partner to be able to have a full understanding of the patient is vitally important. So here are a couple of thoughts. So one is being at the decision-making table. I had the opportunity of talking to Dr. Ciatola out in the Shore. He and I are good friends up in Queen Anne's County, I think, right, Dr. C? And we were sharing and talking, and we had this interesting thing he brought up to me. He said, you know, Roderick, there are no, as far as he knew, he didn't think there was a health officer on any of the boards within UMS. And I was like, that's interesting. And I did a little digging, and I think he might be right. And he's the only health officer on the corporate board. Oh, really? Yeah. So I think in terms of, you know, being at the decision-making table, as hospitals are thinking through all this work, right, around equity plans and what they're going to do, it's going to be vitally important that we have a public health person at the table. Right? Or as a mentor of mine shared with me many years ago when I started in my public health policy career, he'd say, Roderick, if you're not at the table, you're on the menu, right? So another reason why we need to have public health in those conversations, right? All right. I mentioned around the turn the curve work. So, right, when the hospital team are looking at what are the factors that are driving the root causes, they have a blind spot. They don't quite know, unless they have a community health person, they don't quite know what's happening in the population health side or the public health side. So that's another space where you guys can help us and say, hey, look, we've got community health workers that are going out in this community, and they can tell you exactly what's going on with these moms, right? Or we have an outreach program, or we have a mobile unit, and we know what's happening in these communities. So these are ways that you can help us to understand the whole narrative around the turn the curve and what's driving some of these disparities. Key role is serving as a gateway to the community. Look, to be honest, hospitals have been in these communities forever, but they actually don't really have a connection to the community there. And really, it's public health that has that connection because that's the world that we play in. And so helping to serve to make those connections, either through leveraging community health workers, either working directly with the health department to get to hard to reach communities that normally a hospital or hospital staff can't get to. That's another key way to help us to try to understand. Because again, these problems can't be solved only within the walls of the hospital. Another area is leveraging innovative outreach initiatives, right? So Dr. C and I were talking about this, how, you know, are there ways that we can leverage community health workers, right? As we're trying to figure out how to get out to parents or families, especially when we're talking about diabetics who need to make sure they're monitoring their medications and they're eating healthy and blah, blah, blah. Is there a way to leverage some of the innovative programs that come out of public health that are already in place? And so the hospital doesn't have to create this, right? The health department already has. So whether you're talking about CHWs, whether you're talking about mobile health units, this is what Dr. Ciatola and I were talking about, using the Queen Anne's mobile unit to help the hospital on the shore to get the hard to reach diabetic populations down in Cambridge. Like, is there a way to partner to kind of figure out how to do that? And then recovery experts that naturally usually are within health departments. Other areas around access to population health data. It's really fascinating that I'm now pushing our data analytics team and pushing some of our colleagues to figure out how do we integrate both the population health data with the clinical data, right? Yes, we have a very robust Epic system, like most big hospitals, but that's only part of the picture. How do we begin to think through what population health data or public health data that may exist, for example, CRISP, that we can integrate to the clinical data to better understand what's going on for our patients? And then lastly is around workforce development, right? Around primary care provider education, even giving opportunities for young primary care providers to work in these communities. I come from, as Dr. Lucian, come from the public health service. I was the administrator for HRSA for years. National Service Corps is near and dear to me, right? And to me, it's one of the most effective programs to sort of begin to increase young medical students' awareness around primary care and the needs of underserved population. So is there a way for us to partner with the public health departments in these communities around training and development for primary care providers, community health workers, navigators, and others? Now, since we don't necessarily have dozens and dozens of CHWs, and I don't think that's necessarily the business we need to get into, we just need to partner with folks that do. And so that's the health department, right? And so that's the idea of how we can think through leveraging resources that are already there, but just may not be within the hospital that we partner together with. Okay. All right. So the last thing I was going to share with you guys is this part, right? So this gets to the conversation we were talking about. Part of the challenge, and it comes from the book, part of the challenge, and I learned this from the Casey Foundation, of driving this work is that you have to have clear accountability between the population health result you're trying to get to, whether it's reduced infant mortality, for example, reduced infant mortality for the whole state, and what we call performance accountability. What's the hospital doing? Or what's the health department doing? Right? We often blur these lines, right? So you hear things like, oh, in fact, I heard it when I first came. Oh, since you're in West Baltimore, we expect you to be able to ensure that there's better diabetes control for all of West Baltimore. Now, when I dug into the data, only 28% of the patients from West Baltimore come to us. So where do the other 72 go? Right? It's probably Hopkins patients, probably Luminous patients, they probably go to Mercy, they may go to Sinai, to go to these other places. So in other words, a community is really a shared accountability of all these institutions. And so if you're going to begin to think about how to assign financial incentives, you got to make sure that you're clear about what and who is accountable for what, right? We've kind of generally said, oh, public health is for everybody. Yeah, but that's not true. It's public health and healthcare institutions and nonprofits and social services, all these groups together that help to serve to improve the health of the community, right? So just another way is when you're thinking about a population versus performance is when we frame it and we think about sort of the population health for sectors of Maryland, it's really the resultant indicators, a question of where you're trying to get to, right? That's your end. But how you get there, it depends on the work that we do at what happens at the health departments, et cetera. So each one of us play a part in driving toward that better end. And so the trick is, Chris, is as we think about this financing piece, is how do we ensure that we have this the accountability structure right as we think about who is accountable for what. And this is part of the conversations I've had with Dr. Jarstein. The attribution, right? So one of the challenges with the current model is when they attributed Medicare lives to hospitals, and then there were patients that didn't even come to the hospital, right? You're not going to be able to demonstrate population health improvement that way, right? That's a flawed structure around attribution, right? So the way I try to describe it to folks, and this is when I was teaching, is if you're thinking about, okay, from a population health, we're looking at, okay, in Maryland, we want healthy mothers across the entire state. But when you think about it and you have a trend line to see if you're making progress in that, it's really a combination of who's at the table, who's not at the table, whether it's hospital, and other hospitals, whether it's the health department, and all of us together are accountable for that broader population health goal. And with that, let's say says, hey, we're going to do our part around SMM. Well, for UMS, we're going to have a set of measures to say how well we're doing for our patients. Right? So go back to that health equity plan where I showed you they all had KPIs. This is where those KPIs fit in. So I can tell you at UMS, let's say at BWMC, of all the pregnant moms at BWMC, I can tell you all the strategies they're doing and their KPIs for every patient that comes through BWMC. We could do it for St. Joe's, and eventually we'll do it for every hospital, so that every organization can have a set of measures to say, here's what we're doing and what we're doing to contribute toward that broader population health goal. Right? This is the key to trying to figure out how the AHEAD model will work. We can't use an old way of approaching it. Right? It didn't work the last time. Probably shouldn't say that out loud, but anyway, it didn't work last time. But we have an opportunity now to rethink this. Right? I don't have an answer, but at least I'm hoping that through our collective thinking that we can kind of figure out together and say, hey, let's try this or let's tweak this. So we begin to try different ideas that get us closer, so that we understand who's accountable for what and what goals we're actually going to go after.
You're closer. You've got to be a close person. Getting an answer that's.
Yes. Yeah, we got to try something. I mean, I'm unique because I'm also public health, kind of unusual within a health system role. But I take that as divine ordination. So there's a reason why I'm there in that particular spot. So, and then we can assess whether each hospital or which contributor is doing the right thing. Are we doing the right things? The health department doing the right things. The social service providers doing the right things. Everyone can kind of sense that they're all doing the right things to contribute for the larger population. And so this is exactly what we did around infant mortality in Baltimore. And I would argue that's why it worked. Everybody was doing their part, but everyone knew that they had to assess whether they were doing it well and if it was contributing to the broader goal of reducing infant mortality for all of Baltimore. And the reason this is important is that it moves away from this idea of that one organization is accountable for broad population health improvement. You cannot do that. It's literally impossible, because unless, I guess maybe the shore, but unless you're the only game in town and there's no health department and there's no social services, it's only the hospital, I guess you are the only accountable organization, but that's typically not the case. Right? So I'm going to stop there and give us some time to react to that and see if you guys have questions. But hopefully you found this helpful and you got a sense of what we've been doing. There's a lot more to it, but this was just a high level overview.
So we all have a variety of questions to ask, and as people are queuing up their questions,
Yes.
and we'll start with you. I do want to just recognize some additional commissioners that joined us in the room, and as you were speaking. So Nicole Rochester, who is here as a commissioner as well, and then also Senator Lamb joined us in the room, who was previously online and here in the room. And for those of you who may have missed the announcement in the October meeting, Senator Lamb was also recently designated by the Senate to take on the Senate position within the commission. But he is a very familiar friend to public health and certainly was involved in the authorizing legislation for this commission as well. So it's familiar with the task ahead of us. Also, I had introduced Dr. Levy earlier before he joined us, because he was recently appointed last month as to be a commissioner representing local public health at the urban level. And then online, I saw, and I apologize if I missed you, but online I saw Delegate Bagnall join us recently. And then Dr. Rossman from Howard County joined us recently. Michelle Spencer. Okay, great. And if there are any commissioners who joined us after roll call, I'm sorry that I missed you, but thank you for joining us and feel free to chime up. We're going to move to questions. There's just so much, and I have a page littered with questions. But I'd love to have some follow-up conversation with
Absolutely.
you. But we'll start with Jean first, if that's all right, because I saw her.
Hey, good. Thank you so much. Well, Roger, it's great to see you again. Thank you so much. I don't know if you can see me here. I'm waving at you there. Phenomenal. I love it. We're doing a lot of the health equity plans for health plans. And so I'm excited to hear for some of the blues in other states. And so I love what you're saying. I love the inclusiveness. I heard all of it. I just really want to commend you for such a inclusive process that you are doing. I do want to ask, I don't know, and I know I had to step away for about 5 minutes or so, but I don't know if you spoke about doulas and your work about doulas. So that's just one piece. I wanted to say it is no question CHWs have such an impact. It's awesome. And then I will say this, I mean, the doulas are from a workforce perspective, but I will say, there's nothing, there's no equity without even economics, right? And so I would be remiss, I'm on other small business commissions and what have you, and I would be remiss if I heard you come out the gate talking a little bit about some of the DEI and the HR, I heard, and no Michelle, and just all the many things that you said. But I would also say that, and I probably have a little bit of personal experience with this, and that is really, and you don't have to address it, I just want to put that bug in your ear of thinking about how are you looking at your vendors in Baltimore and how much of the money that is spent in the system is spent in the communities with vendors that are in that community, because ultimately population health reflects community health, and the community reflects the economics of there. And I'll just say, and I can certainly hit you off to the side, but I just want to make sure that is also being measured. And I don't know if I saw that metrics in your group, but that can be a side conversation. I don't want to take too much, but thank you so much. I apologize I'm not able to be there with you today, but it was absolutely excellent. Well done.
Thank you. Can I go ahead?
Yeah.
Okay.
Yeah.
So in terms of doulas, absolutely. I think doulas are going to be a critical strategy, I think, to address particularly around issues of SMM. I think it'll also vary on the context of which hospital that you're in, right? So I think in certain places, doulas will probably be vitally important. But across the board, a big supporter of doulas in the role of supporting and advocating for moms. In terms of the spend, that's another talk, Jean. That
okay. No worry.
So at the very beginning, I don't know if you got to see it. There was a little diagram with 4 little circles, and there was one circle at the bottom around external partners, and that's a strategic priority where we push for supply chain diversity. So we spend probably as a system a little over 100 million a year, probably close to 200 million a year. And we have strategically been increasing the number of minority and women business-owned vendors in the system. So much so that I don't know if folks know Vizient, they're one of the big hospital kind of supporters. We've gotten the Vizient Award for supply chain diversity for 4 years in a row, including this year. And so one of the ones that I'm particularly excited about is that there's an African-American woman entrepreneur in Baltimore that makes natural hair products. And so I don't know if you guys have heard of Olin or Oyen in Baltimore. Her shop is on Greenmount Ave. So she is now a vendor. And what's exciting is that we got all her products distributed across the entire system. So if there are patients of color that are having natural hair products, they now can get access to that, and we support and grow her business at the same time.
Yeah, no question.
So that's a big body of work that we're driving with now my new colleague, Rochelle Webb-Dixon. She's the new Chief Administrative Officer for the system. And she comes from a health system in Milwaukee, and she's passionate about this. So we are actively trying to figure out how do we continue to enhance and impact our economic impact around minority and women business vendors, not just in Baltimore, but actually across the state.
Yeah, no, but in Baltimore it's big because we got to change the economics in Baltimore.
Oh yeah.
So I'm sensitive to that. But please do all you can to get some doulas. We need doulas.
Yes, ma'am. Yes, ma'am.
All right.
I'll let.
So our mandate as a commission is to produce some. Our mandate as a commission is to produce some recommendations in the form of a paper that will get presented to lawmakers. And it's concurrent with this ahead month. And I one commissioner, not a chair, and but I feel like this opportunity is enormous.
Yeah.
Like, because the head model doesn't get shaped off and the commission goes away.
Good.
And I just would love, like, we share an interest.
Mhm.
in health equity. I believe that the commission,
Right.
without exception, shares that interest with your work.
Yep.
You can give us 3 things, or at least one, that we can put in the paper to say, here's how here is a specific change that we can make to the hospital incentive model in the state that will help us advance public health goals, or health equity goals.
Wow. That's a tough one, Chris. I don't know if I came prepared to answer that one. I shared a couple of ideas, but if I had to pick one, it's probably the data integration between public health and the clinical data. Well, Chris is basically our population health data, but we've got to figure out how to integrate that with Epic, right? Because you got 2 different data sources, and if you're going to truly understand what's going on for your patients, you have to have both. You got to have your clinical data and you have to have Chris. So there's got to be something in there that says that we have to integrate those multiple, because there's others too, data sources to fully understand the needs of our population to develop a better understanding of what's driving these disparities. And keep in mind, based on the AHEAD model, every hospital has to do what we just did. They have to develop a health equity plan, right? I don't know if they're fully ready and know what that means yet, but right, that's.
And they have a ton of money.
He's online, actually.
Oh, he's online? Okay. So that's, that integration is going to be critical. Because as I said, what allowed us to drive this work across the system was the data foundation. If I didn't have the ability to create those dashboards and look at these specific areas, and again, those are only Epic data, wouldn't have been able to kind of build the momentum to create a strategy and look at root causes without that integration. So that's one key piece I think is critical. The other we'll have to, we're going to have to be creative, because I'm not exactly sure on how do you attribute some of these things. And thank you, Craig. I appreciate it. We'll connect. You know how to find me. All right, at least
That'd be great.
Brewster and Boris knows how to find me, and Nicole knows how to find me.
Perfect.
We brought everybody together. We're settling an issue. And to that point, I don't want to interject here, but as co-chair, I will, is the fact that, what we're looking for are going to be these practical.
Practical solutions.
Yeah. Right. Something as simple as saying we have Epic, we have CRISP, we have a mechanism. This commission next October is going to come up with a final report.
Yep.
And that final report, we want it to be robust, to be earth-shattering and earth-changing, but also doable.
Yes.
And the reality is that with right people in the room, and we may come back at you. We're
Absolutely.
That report and say, have another look at it. We're hitting you with, give us 3 right now.
Right.
We'll give you time to think.
Yes, I appreciate that. I appreciate that. And just know, Chris, now that we've signed the head contract, the clock has started.
Yeah.
Right. So it's between now and probably July or August that we're going to have to build this thing. Right. And this is our opportunity to say, okay, where does public health fit in here around root cause analysis? Where does public health data fit in here around understanding what's driving disparities? Like, there are going to be multiple places, and there's ways to integrate it and what we do and going forward. So lots and lots of opportunities. I'm sorry I can't give you 3 off the top of my head, but that's why I shared some of my top of the head thoughts on where it can go. And with you, for example, sitting on the board of St. Joe's and Franz on BWMC, you guys have your ear to the ground that a lot of public health folks don't have. Remember, I said I would love to have more health commissioners on boards. That's an opportunity for you all to kind of, as you're hearing some of the health equity plans and you're hearing what BWMC is coming up with, to go, okay, how can we plug in the health department here? How can we plug in public health in this section?
Well, I think if I could respond.
Yeah.
Because I really appreciate what you mentioned. I was going to actually raise that as one questions about data and information technology and integration of that data and the utility of CRISP. But on the topic of hospital boards, so there are restrictions for local health officers serving on hospital boards by the state ethics, unless the hospital board itself writes into its bylaws the position designated in its bylaws
Ah.
on the board for the local health official.
Interesting.
It's a conflict.
I think that is.
Oh, it's a
really
conflict.
important.
Ah,
And until the
interesting.
hospital takes that action, the health
That's good to know. I
official-
didn't know that. Yeah.
A lot of our local health departments contract funds to
Yeah,
hospitals.
yeah.
Right, and so we have to be careful.
I see.
with all
Or you might
that.
have multiple hospitals in your jurisdiction.
Right.
Yeah.
So that-
Yeah, where do you go? Right.
So
Yeah.
I think if funds and other hospital systems are, and I believe rightly interested in ensuring the presence of public
Mhm.
health decisions, then they need to actually change their bylaws. to
I see.
designate this fund for the local
That's
health.
interesting. Okay. I didn't know, I didn't think about that or didn't know that. So that's helpful to know.
And that is a topic I think very relevant to our GOC work group. And I'm actually going to just take the liberty of calling Dr. Brookmeyer, who's the health officer in Frederick County, who may have some other knowledge as well.
Well, actually, I'll say it's a bit more complicated. So I have gone through the process in my jurisdiction, and it was not the hospital, it was another local organization,
Oh.
part of the public health structure. They did change their bylaws. They put in a health
Right.
officer. And the state ethics commission ultimately said that it would present a conflict.
Oh, wow.
Because the local organization
Yes.
is part of a statewide organization. So it's a local chapter.
Got it.
I don't know if there's any funds
Yep.
between them, but the other chapter does do business with the state, and because it did business with the state, it would present a conflict. of interest.
Got it. Okay.
So it was not permitted to even after they went through those.
Got it. Okay.
So maybe that's,
So-
that's a place for potential policy, that.
Yeah.
that
Yeah.
Create.
And recommendation, there is, I was gonna say, there is another
Mhm.
pathway. Sometimes we are permitted to do something as an individual, like say my local community health center. If I were to be on that board, if they were to add it to their bylaws, I would never, in my job, ever be able to speak about the community health center. And to me, I felt it was something for my job as health officer to be able to speak
Yeah.
about.
Yeah.
Yeah. Yeah. Yeah, these are the system changes stuff. You're not- It's stuff like this. Yeah, it's fascinating. Yeah.
Started us off on our mandate, with this report. There's, you mentioned a lot of opportunities. I don't want to be like the fly in the ointment and say there's a threat in the sense that in October, by October, we
Right.
are going to have a major policy change at the federal level with respect to the agencies that we pay close attention to, CDC,
Mhm.
CMS.
Right.
So, some of the inclinations from the federal government as far as policy inclinations may well change.
Mhm.
And so I guess my question to you, we talk about baking it
Right.
into the enduring change, enduring transformation, part of the DNA of the system. And so if there's a walk away from DEI at the federal level, what can this commission interject in our report to get it into the DEA of the system so it is not dependent on some vagaries at the federal level? You see, you know
Yeah,
what
yeah, I'm serious to say. Yeah, 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 yeah.
And you're doing it at arms.
Yeah, yeah, yeah. Mhm.
Strategically building a framework that can be pulled apart, that it is hard. So
Yeah.
I guess we have to look at how we do that in public health to protect the progress that's.
Yes. Correct.
I don't know.
Yeah, that one I don't have an answer to. Right? Oh, did I?
And like, they're
Yeah.
not gonna, like, CMS and HHS is never gonna walk away from healthcare quality.
Yeah,
It's just-
no.
Right, that is part of the.
It's just a matter of how you're slicing the data.
Yeah.
If you're Slicing it by race and race and ethnicity, then you know where to focus some resources.
It's true.
I take that point.
Yeah. And it's one of the reasons why I specifically call out the quality report to Eris Human and the others, because it's not just about looking at a disparity. It's like, we've already said this as a country, that equity is part of quality. So let's just put it back in. And as we drive quality improvement initiative, let's have an eye toward, okay, is this also equitable? Right? And so we have that framework or that spin that we
So
could
it's
use.
not some subsidiary.
Right, it's not the standalone subsidiary, yeah, it's part of quality, right? And we have this, when Dr. Sumter spoke on Friday to the group, that when we launched severe maternal morbidity across the system, we put up one of his quotes is that, you know, his vision is that UMS is the safest health institution in the state. Now, I would argue that if it's going to be safe, it's got to be equitable, right? You can't separate the two. So I think there is enough space for us to think about either the quality argument or the safety argument of saying, make sure that in there that the equity and patient care work is baked into that, right? Because all you have to do is just dig into who are the patients. And once you start to pull it apart, you realize, okay, we can't do this unless we have language translation services on the shore, because now their Hispanic population are exploding on the shore. We can't do this in certain areas, like there's certain things that naturally you have to do if you focus on safety and quality. So.
Dr. Levy had a question.
Yes, sir.
I think we'll probably wrap up after that.
Yes, I'm sorry, I feel like I took up too much time, but.
No, it was the same. Something.
Thank you. Dr. Levy.
So first, I applaud you for being well ahead of the curve.
Thanks. I think. I think.
No, it's tremendous. One of the things I think we struggle with in public health is the financing of things.
Yeah.
And there's the Robert Downs Foundation talked about the wrong pocket problem, which you might be familiar with.
Mhm.
And if we do our job in public health,
Right.
then healthcare saves money.
Right.
And social services does their job, healthcare saves money.
Right.
But then that money doesn't flow
Back to
into
public health.
So it's almost like there's a tipping point.
Yep. Yep.
That if public health does its job well enough, then the cost, should go
Mhm.
significantly down.
Right.
Because people are starting to move towards
Yep.
health and prevention. So how do you bake in
Yep.
that kind of a model so that as public health helps you help patients
Yep. Yep. Yep.
and create equity, that money or that savings can shift?
Yeah.
And it's maybe bigger
Yeah.
issue.
No. It's the question is brilliant. And to be honest, I've grappled with it for 30 years right? When I had my public health hat on. And it's one of the things that attracted me to Maryland. I think in a GBR model, it's easier to figure that out. When you have a fee for service model, it is very hard to kind of figure out if there are savings on the hospital side, how to move it back to public health. Because you got to think of it in the state of Maryland, it's just one big pot of money, right? So some goes to some goes to Hopkins and all these other folks as part of our GBR. But in this global payment, the idea, and I asked Josh this, we had dinner, I was like, is this what you meant? And so the idea was through the savings, some of that would go back into public health and population health interventions, right? And so I don't think that's really been happening as much as it probably could. But that's something that we can bake into this new model, right? So that it's more deliberate, that we can ensure that if there are savings, that the savings, at least partially, should go back into public and population health interventions. And so it's a shared, again, it's this idea of a shared accountability, right? And that's really where I think we've got to shift, and if we're going to make this work, is we can't think of it as, oh, this is a hospital financing thing. This is a health financing thing for the whole state. And within that health financing, there's public health, there's hospitals, there's social services, there's all these groups that play a critical part in it. And the model potentially can give us a chance to figure out how to have some funds flow back into that like a public health trust. Like that's what we had when I don't know if folks remember the ACA when we first created it. Forrest probably remembers. You were there. I was in the Fed. When we first created it, there was a public health trust. And the idea was there was money going in there to help support public health interventions. And so is that something we can consider for the state? Should there be something like that? So anyway, I think the new model gives us space and opportunity to think of a lot of different possibilities on where
Maybe
funds
we
flow.
could build that into some of our recommendations.
Build it into the recommendation. Right?
Can you talk about like one or two specific areas where you think you could help the hospital achieve if it's like the Healthy Moms program?
Yep.
Like, are there things that you can get paid to do that will help them to achieve their Goal?
Nurse family partnership. Healthy families.
Healthy families.
Space,
Right,
home
right.
visiting
Home visiting programs. Right.
Implementing, but are doing on shoestring grants and are supplementing with
Right.
5 other kinds of funds to try to make it work. And
Yep.
and so forth. Yet these are preventing, you know, postpartum complications. It's promoting healthy pregnancies. It's promoting very great outcomes in early childhood.
There's things,
yeah.
there's things the health department is already doing. But it's just not tied to the hospital patients and sort of a continuum of care, right? And so that's what I was referring to with Dr. Ciatola on the shore, because he has a whole mobile unit. And, you know, the new hospital in Easton is going to have to be able to access these hard to reach communities, right? Down in Cambridge and other places. Shore doesn't have a mobile unit, but Dr. Ciatola does, right? So why can't, he's already supporting it. Why can't he partner with Shore Hospital and say, hey, we'll go out and we'll make sure we do the screening for all the diabetics down in Cambridge, right? That's part of that. And then we'll bring all that information back to the shore and we'll make sure that there's some way to connect patients back if they need follow-up. So there are stuff health departments are already doing. It's just trying to figure out what those things are. Yeah. Community health worker programs, right? CHW programs, outreach recovery programs. There's a lot of stuff, but it's in these silos. Yeah.
Because if you'll say it, then we should do it.
Yeah. So that's really, to your point, that's really from the hospital side. Remember, I'm trying to change their mindset. From the hospital side, where I'm trying to get them to dig down to understand what's driving that problem. Because if you drive it, if you get a better understanding and say, okay, here's what's causing or what's making it difficult for diabetics to control their blood sugar, or here's what's making it hard for moms in delivery, you eventually go, yeah, if they're not getting in, we probably should have a home visitation program. Thing, Dr. Levy has one. Then you just roll over to the health department and you figure out how to connect the two, right? So the hospital folks have to begin to grapple with this mindset that there are things that are happening outside that are driving what we're seeing inside the hospital, and then go, okay, who's doing that? And then the natural answer is our public health infrastructure that's already doing it. Right? So it's not like we have to create these new programs for this; they already exist. Sorry.
I just don't know. I think this is fabulous, and
Right.
honestly, we could really go on for hours. But I'm just thankful for you,
Oh,
and your
thank you.
work and your team's work, and thank you for coming to the commission to talk about this work and some thoughts you have.
Great.
That intersection of healthcare and public health. I think there's probably a lot of thought seated across the commission and across the members of our work group that have joined us today. And we'll certainly be following up with some
Great.
follow-up thoughts as well and
Excellent.
ways to keep you engaged.
All right. Well, thank you guys for
Thank
having
you
me.
very
Yeah.
much.
Thank you.
So we're going to, I'm just going to take the chair prerogative here of shifting around the agenda a bit, given time. We're going to move into a 10-minute break at this point. When we reconvene, Shane Hackett, our manager, is going to give a quick update of where we are with the commission since our last meeting. And then we will be really excited for our last presentation of the commission to hear Dr. Catherine Feldman speak about the state health assessment and improvement plan. Okay, thank you. We'll go to 10-minute break. Thanks.
Nobody was around. No, I did that. Fran does. She was there. That's it.
All right, let's get everybody back into their seats. Make sure we still. All right, everyone, we're gonna go ahead and reconvene and appreciate the short break. And you can have everyone's. We're gonna get all of our commissioners back to the table. Shane, we're still recording, right?
Yep.
Yes. All right, so just want to thank Shane Hatchett, our commission manager. We are very grateful for all the support from the CDC Foundation to support the process that we're undertaking here in Maryland. And Shane is, of course, from the CDC Foundation, as is Sarah Bora, who I think may be online. Okay, great. And Megan Roney, I think, you joined us sometime as well from the CDC Foundation and supporting the commission. Dr. Yashanka Kleinman wasn't able to join us this commission meeting, but from University of Maryland, serving and providing some expert consultation to the commission process.
Great. All right. Thank you, Mina. So as we typically do for this, we've got an update on our timeline. We have made some modifications here based on recent conversations and what we've learned around these deep dives, how they've worked, and what we can kind of modulate and tweak a little bit in terms of compressing our timeline a bit. And so we're going to recalibrate this schedule altogether and send out an update in the next several weeks. But what's most important for this group to realize is obviously we have our November 20th meeting that will be virtual only to solely discuss, review, and make any revisions to the interim report, which I'll talk about a bit more here in a bit. We previously covered this, but just for purposes of refreshing, the deep dive for funding has been scheduled for December. Originally was scheduled for this meeting. So Dr. Polsky and that work group will go over the funding deep dive in December when we meet on the 5th. We may have some speakers, may not. We're still working on what that might look like. And then for the 23rd of January, our first meeting in 2025, we have moved the data and IT deep dive to February so that we can have more time for a kind of policy and infrastructure panel. We're currently working with the National Public Health Law Group, Kathy Hoke in particular, and a couple other entities about putting together a panel similar to like the workforce panel that Tosin had organized previously, so that we can dive a little more deeply into some of those kind of national conversations of, what do boards of health look like, et cetera, and things like that, as well as myriad other things. So that's a pretty significant change from how we had structured this before. So we'll have 2 deep dives scheduled in February. And because of that, we won't have any speakers at that meeting or the following meeting in March, more than likely, just to make sure that we've got time to really deeply address those topics. Because you'll notice here on March 13th, we have recommendation presentations from the Governance and Organizational Capabilities Work Group, Communications and Public Engagement, and Funding, which are the 3 work groups that would have substantially presented their deep dives well in advance and had time to kind of start working through things. Obviously, more guidance and context about what that looks like and how the presentations can flow, or should flow rather, is still in conversation, but that's kind of the plan for now. Fran, I see you kind of thinking.
Yeah, so March recommendations from a couple of work groups, governance being one, obviously. So how does that sync up with findings from the assessment?
Yes, great question. We are still working on finessing what that timeline looks like. It has been a bit slower than we originally envisioned. But I believe we'll have most of the information around February, except for the public health wins component, but we need to double check that with Dr. Aria and Dr. Hawkins and the other folks. But
Yeah, so
go ahead.
part of the conversations we've been having is what delay in the timeline of recommendations do we make in order to allow the work groups time to digest all the information. Because the recommendations, of course, are based on the data. And yes, we've gathered a good amount of data thus far through site visits, public commentaries of listening sessions, these speakers, the speakers to the work groups, et cetera. But we need the assessment data that the team is currently working.
Yep. So to that point, this is still kind of draft the further to the right that you get. But that's why we update it every time we have this, because it does change. And so obviously the things in red are things that have been updated. Right. While I'm here, I do want to just personnel wise share that Jay Atanda, who was one of the co-chairs of the data and IT work group, had to step away from that due to some other commitments. So we are looking at how to backfill that role and what that looks like basically for the next 10 months or so to make sure that Dr. Levy is not wearing too many hats at once. All right. On the topic of the interim report, I know that the work group co-chairs as well as the commission co-chairs have seen kind of that first draft. It is still very much a draft. We've got a lot of good content and feedback from those conversations. Right now, it's about 20 pages, excluding the appendices. And so we really are being thoughtful about how do we communicate a thoughtful, coherent message to the General Assembly, who asked us to make this report, but also the executive branch, who will be receiving a copy of this. And it really goes beyond that too. How do we communicate this publicly and really drive interest and making sure that this is a really great opportunity to highlight all the work that we've done so far without getting into all the little minutia that will really be more appropriately covered in our final report that we issue in October. Go ahead, Chris.
Oh, okay, so I mean, I just, and Senator Lamb, you might have to probably refine this, but I think we really want to 20 pages can't be like the headline here. It's got to be like we've got 5 key points or 3 key points or something that is digestible that will actually start to get people talking about this.
Yeah. So to that point, yeah, that the 20 pages was.
Yeah. But like, I mean, in terms of
Yeah.
breaking things in effect.
Yeah.
Yeah, I mean, so one, like a brief executive summary would be helpful, once this is done. Two, I think it would also be helpful, and we can reach out to the appropriate committee chairs to just do a short briefing to the Senate Finance Committee that has health under its jurisdiction, also to the House Health and Government Operations Committee. Oftentimes we have briefings at the beginning of the session, so this would be, I guess, not for the 2025 session, it's probably the 2026 session. In January 2026, a long time away, having that briefing to review what this commission has come up with, I think would help.
For the final, but that would be towards the final.
The interim report.
Oh, you don't know.
The interim report would impact the next thing.
Oh, well, for the interim, that's
Yeah.
January 2025.
So, yeah.
Yes, we're happy to facilitate kind of reaching out to the appropriate committees. Thinking we can get, just a short briefing.
Well, what is effective? Like, if somebody's communicating to the center, should we be focused around, like, if you were receiving this, or you were with someone else, but like, should we focus on maternal health? Or should we be talking? What's the best way to get the message across that will actually resonate? Like, should we get in front of a public health and specific things where there's big problems? Is it dollar, is it,
So
costs?
I think there will probably be some desire to have some guidance from the commission in terms of, these are our top priorities. These are how we would suggest that you look at them in what order, right? The dollars are going to be hard. Dollars are going to be tough to come by given the state's budget environment. So, everything's kind of budget control kind of positive. I think what would be really helpful for policymakers are specific policy recommendations that would come out of this that we could easily pick up and turn into legislation or turn into a budget request that we put in for additional public health infrastructure. Those would be, actionable pieces of recommendation that I think we can pick up easily, most helpful for us. Because I think their intention split. So having something very specific and action.
I think, this is an interim report. We don't have all of our assessment data out. In fact, we want our recommendations to be informed by the assessment that we're taking all this time to do. So I think this report as an interim report will focus more on what's happened thus far and some maybe early themes that are emerging out of the work groups. Whereas the final report, for sure, obviously, that's really where we're hoping to include all of those recommendations that have been informed by the assessment data and so forth. I'm gonna just, if you don't mind, just because we have Dr. Feldman, I want to make sure we have that time for her to. Shane, do you have any key things to wrap up with, and then we can move over to Dr. Feldman?
So November 14th to the 19th, that's obviously the really important piece where the commissioners will have the opportunity to provide substantive feedback and input prior to our meeting on the 20th. And that's when we'll kind of come together and work through those different pieces. That's probably all I need to say on that.
So Shane, let me add, I'm going to be chairing the November 20th meeting. It's our first meeting where it's all going to be virtual. This is a special meeting. The only agenda item that meeting is for us to adopt the interim report, period. Okay? So we can do it in 5 minutes, or we can do it in 3 hours.
Nope, we scheduled it for 2
2 hours. 2 hours, right? I'm just warning the commissioners that preparation for that is going to be so critical, right? So those 5 days, the 14th to the 19th, that we have, really, that's the time period to sort of look this over. And in essence, I'm going to reemphasize what we've said already. This is an interim report. It is an update to all the parties out there saying this is what we've done. And in essence, without us over reading and getting to big recommendations, we don't have the assessment done. We don't have all the data in. It's going to list themes that we've seen, but it may not satisfy all your desires, right? Of saying, oh, we should be already recommending this, right? Compared to last year, when we issued, the three of us issued the December 1st report where we hadn't even met or met once as a group. I mean, we had that report was in essence required by the legislation, and it said nothing. This one is going to say you're going to be blown away, actually, of how much work has been conducted, because we only see the work in this room the commissioners do. But there's a ton of stuff that the work groups, especially people who are intimately involved in work groups, are doing. They are to be congratulated for stuff that's been going on, but also we're to be congratulated because we've sat through multiple meetings already, learning, discussing, getting stimulated with this. And I think that's going to be reflected with this report. But again, I can't stress enough, let's prepare ourselves. If there are we looking for a comment period early on, right? So get your comments in so that we don't spend time at that November 20th meeting going sentence by sentence. Right?
So, Chris,
I just
one
want to,
time.
if you don't mind, just let me add to what, just like I said about the report, I just want to also, in addition to describing our process, you might see some just key policies that have impacted our work thus far. This is important, but we will be touching on just some key policies, right, that have impacted our work.
I'm more focused on 5 years from now when we look back on what's been, what's different. And you just heard me tell you there's no new money. There's no new money. Now, the only money that could be there is through changes in the rate setting process, which is happening concurrently. this interim report is our chance to influence that process. So like, if we don't focus on that, we will miss it. So it's 3 things, it's 5 things, it's something we have to see. We have to at least put a hypothesis out there so that it starts inserting ourselves into that model process, or it'll just happen.
And I think you'll see that through the narrative that we've woven together in the report that contextualizes the work of this commission amidst the entirety of what the state of Maryland is doing, whether that is the Health Equity Commission, whether that is the Community Resources Commission, and some of these other folks that have been doing related and somewhat similar work, but not exactly the work that we're doing solely focused on public health. So I don't mean to cut you off, but I think once you see it, you'll find that some of that's addressed there, and that the themes lay out those breadcrumbs for what we would expect to see in the final report that does touch on those concrete things like rate setting or how do we pay for some of this equity work. So all that to say, Dr. Feldman had a pretty significant presentation. My slides are out there. If you have questions, we can chat more about that.
Thank you, Shane, and to Chris's point, that's something we'll take back and talk about with the team.
How far they're gonna guard that money? Here's.
I think it's important for us to acknowledge that, as Chief mentioned, that is written into the draft that's circulated to the chips. But there may be a better space for us to call it out more specifically and to talk about some of the themes that have emerged as far as it relates to that work. I apologize, Rosalie. I know your hand's up. If you don't mind throwing your comment in the comment box. I did see the one earlier. The draft interim report will be, the interim report, once it's adopted by the commission, will be published on our website, as are all of our reports. Let's move over, and I'm going to pass it over to Tosin. She's going to introduce Dr. Catherine Feldman. Thank you.
Thank you, Nina. It is my pleasure to introduce Dr. Catherine Feldman, an accomplished leader in public health and a skilled problem solver, boasting over 25 years of experience in managing public health initiatives. I'm going to use Boris's line now. Just utter those keywords when you hear infectious disease research. There she is. Surveillance, investigations, responses. Dr. Feldman has served in various roles, but currently she's working as a Chief Performance Officer at Maryland Department of Health, where she enhances public health infrastructure through various initiatives, including building a health Maryland. She's also served in the past, the state public health as a state public health veterinarian, and has led, CDC projects, including the Mitral Corporation. She holds a veterinary degree from Cornell University and a Master of Public Health degree in epidemiology from UC Berkeley. She's the diplomate of the American College of Veterinary Community.
The water cup there is yours.
The water cup is mine. Wonderful. I'll try not to spill it on the equipment. Wonderful.
And do I need to play with this thing? Okay, well, thank you so much. This is such an honor to be invited to present to the commission and to see so many people who I've crossed paths with over the course of my career, whether they hired me back to MDH after a little bit of a break, Fran, or Mina and I, one of the last things I did when I was the state public health veterinarian was investigate an outbreak of swine flu in humans. And so Mina and I got to know each other and text each other rapidly on that. I also wasn't sure how I'd follow Dr. King, but I will tell you, he set the stage beautifully. So many of the things he talked about are now going to, we'll share the public health analog or ways that there's a lot of synergies in the work that we're talking about. Okay, well, without further ado, let's go into talking about building a healthier Maryland. And I'm going to specifically tell you about the state health assessment and state health improvement planning to tell you how that fits into our Building a Healthier Maryland initiative. So if you're not familiar, and I think maybe you've had some discussion on public health accreditation, I'll refresh your memories about public health accreditation and the major plans that are required for an accredited health department. That will lead into a discussion about Building a Healthier Maryland. I'll introduce you to our just recently released state health assessment and state health improvement plan, as well as introduce you to the current SHIP metrics, which again align really nicely with what Dr. King was talking about. And the need for data and the need for data that can be disaggregated and really shed light on gaps and areas for improvement. Quickly touch on SHIP alignment with the head. That's so much a work in progress that I'm just going to touch on that because it's early days yet, but then also just direct you to where you can find the SHA and the SHIP. So what is public health accreditation? It is voluntary for a start. That's one thing I know all of you in public health probably appreciate. But speaking to folks who come from the healthcare community where accreditation might not be voluntary, it can be hard to wrap your head around that this is something we voluntarily pursue. We go to extra measures to work through the accreditation framework to demonstrate that we can carry out the 10 essential public health services and deliver the foundational public health capabilities. So accredited health departments are recognized for meeting national public health standards. It's an incredibly rigorous process. And again, it's voluntary. So people might say, why do you do this? Why are you going to go through the effort to work through all of the requirements and expectations for accreditation? Well, it demonstrates accountability and transparency. Maryland residents know that they're being served by an accredited health department and that we are held to account for the public health services we deliver. It should build credibility and trust in the health department and in the services that we deliver. And then, just as Dr. King was talking about, the whole performance management, quality improvement, the accreditation expectations are such that we have a performance management system that underlies the work that we do at the health department and allows for continuous quality improvement, and thereby identifies areas for improvement. So it's really a nice framework that requires a lot of a health department, and I can assure you that not all health departments are able to measure up to the standards of the Public Health Accreditation Board. So MDH was initially accredited in 2017, 5-year reaccreditation process. A little thing called a pandemic upended our 5-year cycle, and so we're a couple years behind. But our reaccreditation application is in process, and in fact, we are in that home stretch. We are waiting to hear any day from the Public Health Accreditation Board on our accreditation status. So fingers crossed, it's just going to be straight up accreditation, but things have gone well so far. So we had our site visit in late September, and that went well, and so we're just eagerly awaiting the outcome. And the wheel I'm showing you here is the 10 essential public health services. I'll point out, if you weren't familiar, and I'm confident you all are, this was relatively recently updated to have equity at the center of this. So equity should be foundational to all of the public health services. Okay, so moving into the SHA and the SHIP versus the CHA and the CHIP. So the State Health Improvement Plan and the State Health Assessment and the State Health Improvement Plan provide a structured framework that allow us to improve community health and address disparities. And as you heard, I'm a public health veterinarian. I come from an infectious disease background. I really had to get myself up to speed on a lot of the frameworks and the expectations and the intent of all of these assessments and plans. One of the key things I wrestled with was a CHA versus a SHA. A community health assessment and a community health improvement plan in a local jurisdiction to me is very intuitive. You have a local community, you work with your partners, it makes a lot of sense. The SHA and the SHIP is a little bit fuzzier because it's bigger, right? So you have a state health assessment and a state health improvement plan. And it is the same basic premise. Your community is the state. It's just that you might be a little bit more distant at times from the community, or you might engage the community in slightly different ways. But then there's also the elements of engaging the community the exact same way you would if you were in a local community. And often that's how the state works to engage the communities in the implementation, in the development and implementation of the SHA and the SHIP, and you'll see that. Really key here, and Dr. King mentioned this, so thank you, Dr. King. I keep referencing your talk. This is really shared accountability. This is state health improvement we're talking about here. MDH cannot do this alone and doesn't intend to do this alone. This is really an expectation that a diversity of partners are going to come to the table to identify priorities for Maryland and then work to make those improvements across the state. MDH is a key player and facilitated this process, but this is really a statewide plan that should be owned by the entire community. So again, just to define these in more specific terms, the state health assessment is a systematic approach to collecting, analyzing, and using data to educate and mobilize communities, develop priorities, garner resources, and plan actions to improve the public's health. So it's that systematic assessment of the health of the state. The state health improvement plan then builds off of the priorities and the gaps that were identified in the assessment. And it describes how the state health department and all its partners, as captured in the public health system, and the communities it serves will come together to address those priorities and improve the health of Maryland residents. So this is a graphic I got from colleagues at the Association of State and Territorial Health Officials who were very helpful in us as we moved through our SHA and SHIP process. And we lovingly call this the hamburger diagram. But if you look at it, it helps describe how the community-owned elements of the major plans that are required under accreditation, the community elements that are on the left, the state health assessment and state health improvement plan, again, owned by the community, then inform our agency plans. So the top green bar is the Maryland Department of Health strategic plan that should be informed by the state health improvement plan. Again, everything in the state health improvement plan, it's too much for MDH to take on. So what can MDH take on? That's captured in the strategic plan. That then informs the development of our workforce development plan, and Vanessa Lammers, our workforce director, is here. And it helps inform the emergency operations plan and our quality improvement plan. So what comes from the community in our state health assessment and state health improvement plan then informs the development of all of these other plans. The bottom bun of the hamburger here is our performance management framework. Again, so essential to monitor performance, make sure we're making progress on the initiatives, and tweak if we're not. And then at the top bun is our health equity and alignment with stakeholders, partners, in the community. So again, that encompasses the entirety of this framework. So the SHA SHIP cycle, it is cyclical. It isn't like you do this, you put it on a shelf, and you come back next time you're up for reaccreditation. So if you start at 12 o'clock here on the cycle, that's our assessment. That's where we review our data. We take a critical assessment of where we are, where Maryland's health is. We understand who our partners are through a public health system assessment. And then we move to 3 o'clock with our state health improvement plan. We identify the gaps. We then prioritize the areas for improvement. At 6 o'clock, we're implementing the strategies to address the SHIP priorities, and we are monitoring to demonstrate progress at 9 o'clock. And as we monitor progress, we're going to tweak and adjust as necessary. And this is a continuous cycle so that it's not a one and done, put it away and come back a few years later. So building a healthier Maryland was the initiative we launched to develop our state health assessment and our state health improvement plan. And again, this is MDH facilitated, but draws on and builds community across a number of Maryland partners. So all of these folks listed here were cobbled together. In public health, we do what we need to do to get the job done. And we assembled this group of individuals and produced some really quality work as part of building a healthier Maryland. You'll note in the bottom, again, we received technical assistance through the Public Health Infrastructure Grant to work on this initiative. And I can't tell you how helpful that was. They've really set the bar high for TA. And so really delighted to have had their support as we worked through the development of the SHA and the SHIP. So we convened a steering committee, and these were going to be the representatives that came together, reviewed the data, worked on developing the priorities, came up with our goals and objectives and our strategies. And I know this is hard to see. You can access the slides after, but you'll see that we have representatives from Maryland Department of Health, a number of key leadership representatives from behavioral health, Medicaid, Minority Health and Health Disparities, and Prevention and Health Promotion Administration, along with Dr. Kalyana Raman, who is up in our upper right corner here on the screen. He was our chair. And then we had representatives from local health departments, 4 health officers from our local health departments. We had several local health improvement coalitions represented on the steering committee. Halfway through the process, we invited representatives from every LHIC to come and join the planning process, but we had 4 explicitly named on our steering committee. We also had representatives from a number of other sister state agencies who are critical for moving forward with a number of our health priorities. And then we had community representation with the Mid-Atlantic Association of Community Health Centers, Maryland Hospital Association, Maryland Rural Health Association, and the Maryland State Medical Society, MedChi. So it is a whole state, it's huge. So you have to walk that line of getting the right representation and being able to still corral the cats. Forgive my animal references.
You're a vet.
I am a vet. I can't help myself. So our steering committee members were tasked with reviewing the data and prioritizing issues for action, helping us identify metrics associated with each priority to demonstrate progress, reviewing and approving all of our final work products, and then really being champions of this work. So being champions in their communities, champions in their agencies. And so we were really delighted by the enthusiasm of our steering committee. We wanted to get input from the community, so we had a survey that went out and we advertised through a number of different avenues. I know many of our local health department colleagues pushed this out in their communities, but this was for individuals to respond to give their voice to what they considered the most pressing health issues and affected populations in their communities were, and to define who their communities were. We had categorical and open-ended questions. We offered the survey in a number of different languages, and if we had a request for another language, we would quickly get it translated. And we really tried to push this out far and wide. We also conducted a public health system assessment, and that's an assessment of organizations where we wanted to capture who are all of the partners out there contributing to delivering public health services in Maryland, whether they're community-based organizations, faith-based organizations, hospitals, community clinics. And so this was another survey that went out. And in fact, this one is still open. And so we are happy to take more input on this. And the intent here is to produce a directory, essentially, of services across the state for folks that contribute to public health services, but then also to tap into these resources as we develop strategies and implement strategies that address the identified priorities. So I'm going to move now into just showing you some excerpts of our state health assessment and state health improvement plan. So this is our Building a Healthier Maryland state health assessment. We have a section at the start that tells about the methods that includes primary data collection, as I just described, from the community members. We also did an environmental scan of the local health priorities, and I'll show you some shots of that. And then our secondary data review. Well, I'll show you in a minute, but we included both primary data collection, assessed local health priorities, and then did a secondary data review for our state health assessment. So these are some of the results of our community input survey. That's the one, the individual level responses for what are the most pressing health issues in the community. And you can see that we had representation from across the state from the map. If the county is colored in, we had responses from there. And the orange and red are where we had the most responses. Let's see, in the upper left here, the most important issues affecting the health and well-being of the community, as indicated by our around 5,000 responses that we captured. Number 1, mental health. Number 2, access to healthcare. Number 3, homelessness and affordable housing. Number 4, chronic diseases. Number 5, gun violence. So this was one of the direct inputs we took when identifying our health priorities. We did a lot of, we took a lot of the qualitative responses, and people were very eager to tell us why they selected what they selected. And the quotes are very compelling. So I would definitely recommend folks to dig into the state health assessment and read a lot of those. They very compelling. I mentioned the local health scan. We looked for any community health assessments published between 2020 and 2023 and included those in this assessment. And we identified 22 of them from Maryland's 24 local jurisdictions. From that, we took the priorities and we had to bucket them because there were so many things that were kind of the same, but not totally the same. And we ended up with 7 different buckets. And if you look at this graph, you can see the 2 really, really tall, rusty orange red bars. That's cancer and chronic conditions and behavioral health. And so those 2 just really jumped out as being priorities. And then I can't even read that. Access to care, women's health, a number of other things were captured. Because there were so many, the responses in the cancer and chronic disease and the behavioral health were so overwhelming, we then disaggregated those data to look at exactly what contributed to them. So things from substance use and mental health, diabetes and heart disease. So all of that was considered and in looking at our data to identify priorities. We went to the county health rankings model to review secondary data. And if you're familiar with this data, with this model, it lists various ways to bucket metrics in health behaviors, health factors, and health outcomes. So the health factors range from health behaviors to access to care, and then the outcomes include length of life and quality of life. And so we used that to focus across these 6 different areas. So we captured metrics on health behaviors, clinical care, social and economic factors, the physical environment, length of life, and quality of life in these different focus areas. And so I'm going to show you just a few excerpts from Area 5, length of life. This is one of the health outcomes sections. Again, we included more quotes, so definitely would recommend you getting in and reading these quotes because some of them can really make you tear up or tug at your heartstrings. So length of life, we included data on the leading causes of death. This striking graphic demonstrates how heart disease, cancer, and stroke have been the top 3 leading causes of death forever, going way back before this graph. But then you see on the right that little blip where the stroke line goes down, and that's COVID. So that shows you how COVID just really bumped everything else out in 2020 and 2021. We were able to present disaggregated data when we could. We tried as hard as possible to get data that could be disaggregated to all the various variables, race, ethnicity, gender, age, geographic area. Identifying those data are not always so simple. I'm sure everyone here can relate to that. But for example, here is looking at some firearm deaths and injuries by hospitalization versus ED visit only, by fatal versus non-fatal, and by age. Here we're presenting some data on infant and maternal mortality, highlighting the real stark disparities for maternal mortality in the lower graph of Black women versus white women. And then the bar graph just above it demonstrates the much increased maternal mortality by educational attainment as well. So many different ways to look at these data to allow us to know where our biggest challenges are. And then we presented summary tables for all of those metrics. So this is just rolled up state aggregate data. The leftmost column is the metric itself. The next column is the Maryland rolled up metric. We benchmarked it against the US. We had discussions, benchmark it against other things, but we chose the current US rate, and then we provided the data source for that. Anywhere that Maryland was worse off than the US, we made that red. You might be familiar with our previous SHIP from 2014. Anytime there's a metric with this little doohickey, I've never learned what that's called, that indicates it's a metric from the 2014 State Health Improvement Plan. And so we have these comprehensive data tables for each focus area. So that's the SHA. And you can see a lot of information can be gleaned from that. And so our steering committee reviewed that. We asked the steering committee if they had additional data that we hadn't considered. They were able to bring forth data. For instance, MDE was able to provide some environmental data we didn't have previously. And so then we moved into setting priorities and developing our state health improvement plan. So here's our state health improvement plan that is distinguished from, differentiated from our state health assessment just by those words in the lower left. So you have to look carefully to know which document you're looking at. And taking all of those inputs from the community input survey, from the environmental scan of the local priorities, from talking to our steering committee and polling them, these are the priority areas that we landed on for our state health improvement plan. So chronic disease, access to care, women's health, violence, and behavioral health. I don't think any of these should be a surprise. That's what we've been hearing. We heard consistently. So, so those are the 5 health priority areas. Have to explicitly mention equity here. We had actually considered, we had a very robust discussion, should equity be its own priority? Yeah. So we had a very robust discussion. Should that be called out and be its own priority? And we decided no. We want it to be included in absolutely everything and not called out on its own. So the intent is that health equity is baked into every priority, goal, objective, strategy that we put into this state health improvement plan. And we call it out when it's really, when it needs to be called out as well. And I'll show you how we call it out in a minute. At the bottom here, hidden behind the little annotation squiggle, is also a call out to social determinants of health. So that's another thing we wanted to be very mindful of. And what are the social drivers of health that we could be addressing and calling out and thinking about as we talk about health priorities and health outcomes. So to that end, we have little icons throughout the SHIP. I'll show you the structure of the SHIP in a minute, but we have goals. We have our overarching priority, goals, objectives, and strategies. For if the strategy is expressly addressing health equity, then it gets that little equal sign icon. If it's a strategy that is addressing social determinants of health, it gets that little circular thingy. If it's a policy and systems level strategy, it gets that government institution icon. We worked very closely with our local health improvement coalitions on developing this. And if they brought forth a strategy and this was aligned with a strategy that's being implemented at an LHIC, then we wanted to call that out. Oops, I am. Very nice. Then I'm going to go wild now, except now I can't make it happen when I want it to happen. Anyway, we use the little handshake for our LHIC associated strategies. And then for our objectives, if it's an objective that expressly addresses a health disparity, then we put on that little star. So again, introducing you to the structure, I'm not going to go through the whole SHIP. I will introduce you to the goals. But we have priority area 1, chronic disease. Under that, we have 2 goals: enhance primary prevention of chronic disease. So we have that primary prevention piece. And then goal 2, enhance screening, treatment, and care for chronic illness. So 2 giant overarching goals. We pulled out some more of those quotes from our community input assessment. I'll also point out we attribute those quotes to by jurisdiction. So if it's Kent County, as this one is, Kent County respondent, we call that out there to ensure that folks feel heard. Then moving into drilling down on this. So again, here's our priority area 1, chronic disease. Our second goal, that's screening, treatment, and care for chronic illnesses. We have SMART or SMART-E objectives, SMART-E incorporating the equity. And so here we have reduce the rate of emergency room visits for asthma among children. And we have the current rate and we have a target. And then this one explicitly calls out for Black children from 19 to 9. I didn't read it. State aggregate 7.8 to 5.3 for Black children from 19 to 9. So here in our objective, you can see that there's a stark disparity and we're calling out specific targets and objectives. We indicate where the targets came from. So this was, these targets were developed with our Environmental Health Bureau. These also, if you're familiar with SciHIS, this is an objective that carries forward from former work for health improvement. And so that's how we present our objectives. Under the objectives are some suggested strategies that can be implemented to address this objective. And you'll see that's where these icons come into play. So we have the first strategy is specifically addressing equity. The second one is addressing social determinant of health. And the third one is calling for a policy system change and was put forward and is in alignment with LHICS. And then finally, we have the data source for this metric. Oh, and you can't see it behind all this other stuff, but this is another disparity targeted objective. So this whole objective is addressing a health disparity. For our second priority area, access to care, we have 3 overarching goals: enhance care delivery models to meet the needs of different populations. The second goal is to recruit and retain high quality healthcare and public health workforce. And goal 3 is reduce barriers to care. Our third priority area, women's health, 2 overarching goals: improve maternal health outcomes through improved maternal care before, during, and after pregnancy. And then the second goal has a focus on breast and cervical cancer prevention, screening, and care. Our fourth priority area, violence, reduce firearm-related suicides, homicides, and injuries. And then the second goal is to reduce the rates of and harms associated with intimate partner and sexual violence. And our final goal, behavioral health, our final priority, has 3 goals: expand access to and utilization of behavioral health services, reduce disparities in mental health outcomes, and reduce overdose and the negative health outcomes associated with substance use. So again, if you were to access the document, you would see for each goal, objectives, specific objectives, SMART objectives with suggested strategies. So that has resulted in around 31, 32 metrics, depending on how you slice and dice, for our SMART objectives. We heard about AHEAD earlier. We have this historic agreement signed on Friday. Woohoo! We want to be in alignment with AHEAD. We don't want SHIP and AHEAD to be at cross purposes. We don't want there to be work done for this that then is not what's going to happen with the lead. So with AHEAD. So there is a lot of thought being given right now as to how to align the SHIP metrics with what is coming with AHEAD. Of course, AHEAD is in its planning stages. So as was always the intent, this is a continuous cycle of improvement and evolution. So these are our current 2024 SHIP metrics. They may evolve and they may evolve relatively soon. So again, just calling that out as we really zero in on the population and health equity pieces of AHEAD, the SHIP will evolve and change to reflect that and align with it. And that's all I've got. So happy to take any questions. I know there was at least one question asking where you can find these documents. And so this link takes you to generally all of our major plans for accreditation. So you can find our state health assessment and improvement plan there. You can find a scorecard for our SHIP metrics there that currently demonstrates all the state level aggregate data. Click on it and it opens up and things. It's very fun, but it doesn't allow you to drill down and understand data at the county level or by race, ethnicity, or by gender. That's all in the works. It's absolutely essential. It's just not ready yet. So we're working feverishly to develop that. But also you can find our agency strategic plan, our workforce development plan, our quality improvement plan. So if you're curious about things that were recently submitted for public health accreditation, it is all here and available to you. So,
Thank you.
you bet.
Just a real quick question on, I saw that the head of human services was involved in the state, in the health assessment shop.
Yes, the Secretary of Department of Human Services, yes.
It's my understanding that they have not been willing to share data with Chris, so clinicians aren't able to see the social services that citizens are assigned to or have. I mean, this seems like something that would be helpful, so that the clinician can just be one more sounding board in terms of health.
Yeah, I can't speak at all to DHS's data and what's available and what's not available, but I will echo those comments that were mentioned earlier about the need for data and having as much data as possible and being able to disaggregate it. So data is a constant theme.
But
for sure.
it's been resisted for like a decade. No, I don't know.
I can't speak to DHS's data sharing. No.
So
That's
So that is-
recommendation.
that is certainly something our data and information technology workers may want to consider is access to these scope, or sorry, span of data sources that are relevant to public health, public health outcomes, and the delivery of public health services. How can we make recommendations to address that?
It would have no impact on federal, on the state, like, it's all federal, like, right, quick, it's not, good. Then the care delivery team can help patient citizen access to resources.
Yeah,
Again,
and there's probably, this, I think this data topic is a really good one, and I'm glad to hear your sentiments, Dr. Feldman, about the importance of data and the importance of data sharing. Dr. King also talked about this and how a key recommendation he would have is finding better ways to integrate healthcare system delivery data and public health data. I think the key point Chris is making is, well, how do we better integrate utilizing CRISP, which is already existing, and I think we're probably only using a small percentage of the potential with CRISP. If we could bring in some of the social determinants of related data, social needs data, and how we're addressing that from however it's being addressed in different agencies, how can we bring that data into a common system so overlay with health. I would just add to this conversation about data that I think it is critically important for us to have good Medicaid data. We do not have good Medicaid data in our state that's being shared with public health entities and driving some of our public health work. I know there's some NCOs kind of starting with the process of uploading Medicaid data into CRISP. But I don't know, Catherine, if you have the answer to this, or if anybody else might have some thoughts on this. I really feel like we need to do a better job of pulling Medicaid data together, sharing it back at local and regional levels, and ensuring that it's linked to some of what Chris was mentioning as some of that social needs data as well. And then we'll go to Jean.
Yeah, I can't really speak to Medicaid specifically and sharing data back in a general way. I will say through AHEAD, through the SHA and the SHIP, and through just many initiatives, there's this ongoing conversation about the need for data. So I think if we keep elevating what the needs are and discussing them, I think things are more likely to happen. But
You know, London Medicaid contracts are renewed for 5 years.
I'm sorry, I don't. I'm from Public Health Services, not Medicaid. I'll claim ignorance.
Yeah, so, okay, I've got a few years, but we can, so one, I totally love that because one of the most successful initiatives, I know I was a part with CMS, we brought in the Department of Transportation, Department of Housing. I mean, if we know SDOH is 80%, how do we not
Yeah.
bring in these other, when it's all public health, it's all public dollars that are being spent. So totally agree with what you're saying. Oh, Craig is saying something. Although Chris does not have social services data. Thanks, Craig.
Craig,
We're
feel
just
free to
saying-
speak up.
We do have Medicaid data. I'll reach out to Catherine.
Okay, there we go.
Okay.
Okay,
good.
Craig.
Yeah.
I-
that's good.
I,
Yeah.
I will say, sorry, Jean,
No,
don't
go
let, we wanted to have a transportation, smart objective, and we struggled to identify a meaningful data source. So,
Yeah.
so these were, I mean, there was so much thought that went into each of the
Right,
metrics that we landed on. I just, we couldn't find, and I welcome all suggestions. We could not find a meaningful metric for transportation.
Yeah.
I
Okay.
think it goes also back to that point Dr. King was making earlier, is that if you really want to address equity, you have to have that data.
Right.
And you have to have that data as it relates
Right.
to social needs. and
Right,
as it
right,
relates
right.
to the broader
Housing,
social
food,
determinants of health.
Transportation.
And, you know, again, just to reiterate what Chris is saying, I think, what can we do in this state to ensure that that data becomes part of, you know, kind of a, you know, and of course, there's federal and there's privacy laws, confidentiality restrictions, et cetera, FERPA, of course, when we run into schools all the time. But there's got to be a way we can do it and still do it and where we can generate some local and regional data that's useful for meaningful public health action.
And I don't know if that's a legislative mandate. I don't know of politics around that, but to me, I mean, it's all public dollars. So that was one. The other one I wanted to ask you about, congratulations on that accreditation. I know that's. a
It's
big-
not there yet.
Okay.
So
Okay, well,
don't jinx us.
So does NVH's accreditation at all help the local? And I know, you know, the locals need funding to help with that. So just thought about that. That was one. Back to the surveys, I was just kind of curious, were they mailed out, were they emailed? Because I'm always about the patient's voice
Mhm.
and love that you had member voices. I was just kind of curious. I saw your map there, but
Mhm.
just kind of curious to know how many really have a. I
So,
know not statistically.
Right.
significant, but-
yeah, so I'll talk about the survey first. And then I saw that my boss has his hand raised, so we definitely want to get to that. So the survey, we ended up getting around 5,000 responses. We were hoping for tens and tens and tens of thousands of responses. It was good. We offered to send out a paper survey to anyone who requested it, but it was all available electronically.
Okay.
And we did translate it on request to a number of different languages.
Good.
Yeah,
Okay.
so that we did that. You mentioned accreditation in local health departments. I think there are 11 local health departments currently accredited. And there is an information sharing across local health departments and MDH about accreditation and whether documents we submit at the state level can help local health departments. So there's an ongoing conversation. I will say we can definitely build that up. And I've mentioned the public health infrastructure grant. That's one of their focus areas in the grant. I'm the PI on that. And so that is something we really do want to help shore up is help our local health departments
Okay.
pursue
And I
it.
know that Felicia's out there, real quick, results of the side hits, is that out there? Because I was just wondering, I mean, we're building on that. I was just wondering the results. And are there any resources to help to implement this?
So resources to implement the state health improvement plan. That's always the question. We always are trying to work with what we have. That's partly, I mean, that's huge impetus for why we did the public health system assessment, to see who out there is delivering services and how those could be leveraged to either be expanded or reach different communities and things. So I am not aware right now of specific pots of money for SHIP implementation, but we're always mindful of that. So,
To the health department.
yeah.
Okay. Dr. Kalyana.
Hello, everyone. I just wanted to talk a little bit about the data piece because that is something that we're constantly looking at, which is two things. One, how are we sharing actionable, disaggregated data? There's a lot of data. I think the bigger part is how are we going to use it, and what are we going to drive from having that data? And I think that one of the things that I'd like to push for us to think about is really targeted what data is needed, whether it's at the LHDs, the hospitals, the FQs, CBOs, right, to actually drive their outcomes. And then the second is stitching together the data, different disparate data sets, and Craig knows this better than I, is a large task, and I think we're making a lot of headway on that. Talking to other folks around the country, we are way ahead of the rest of the country on this because of Chris, not just how good they are, but how long they've been around. And so I think there's a lot of opportunities coming up ahead. But I would just put out to the commission, more than sharing data is understanding how we're going to use it and what we're going to do with that.
Enrollment services by first at the point of care. So SNP, or SNAP, when who's in, like, if you're enrolled, there's a little icon next to you. And the probabilistic engine is available. Everybody has it. Access. And I think there's concern about privacy. We should be able to solve it.
Did you want to respond to that?
I could not hear the comment, so.
So Chris was mentioning it would be helpful at the point of care to have an understanding for an individual person, right, and in particular in healthcare delivery systems, what types of social needs services they may be receiving. For example, WIC, SNAP, so forth. And if Chris has the ability to do that, how do we navigate whatever laws may apply here in terms of restriction of information to make sure that data can be available to the clinician?
Yeah, point of care, or it could be another person. It could be another, yeah.
Or some public health interventionist who has ability to access that.
Treatment payment operations.
So if I heard that correctly, it's how are we integrating that social services, social determinants of health data into the health data? Is that the crux of the question?
Yes. So if you looked at, I think so, right, Chris?
It's just enrollment data. How do we get the enrollment data available to clinicians?
So a clinician knows that their patient is also receiving WIC benefits and is involved with WIC, for example. I mean, WIC data is actually what we have in the health department, right, in terms of enrollment, but of course there's federal oversight of that program and restrictions may apply. But I think part of the point Chris is making, if I'm paraphrasing correctly, is that we really need to figure out a way to make these social and human service data sets that we do have available within the health department, outside of the health department, et cetera, available in a meaningful way at the point of care for clinicians to live in that healthcare and who really need that, who would benefit from that information at an individual level, and then perhaps to public health entities that may benefit from information at perhaps a subpopulation level or a zip code level. Or
yeah. No, I mean, I think that's where we're headed. I agree with that, right? That's the goal, is integrating these different data streams so that we're fundamentally caring for people, right, and not problems. So, yeah, no, that's where we're going. I hope.
I think you're talking in part about a community information exchange, which Chris is acting as part. But I think it would have to be, the end users of the providers all have to be inside the patient's security zone. Their HIPAA, FERPA, zone in order to be able to share that information back and forth. And it's been done. And it's being done with things like, what is it called? Unite Us and things changed now. And those are community information exchanges. We were working with one called NowPal, which was then bought out by Unite Us, but we were doing a bi-directional flow of information. Try to send it up between and Epic has care, which allows you to go reach out to an entity that is in the network, pull that data into your own network, into your own record. So, and Chris is in the middle of that. And Craig probably is, he's the guru of this, and he'd probably speak to how that might be something that's they're looking at in the future. But it's easy. It's not easy to do. It's we're on the cusp of it.
Craig, you made a written comment earlier. If you had any other comments, feel free to chime up.
Yeah, no, I mean, I think thank you for that opportunity and for all the discussion. I think maybe I would just emphasize Dr. K's comments. Like, there's a lot of data. We can talk through the different types and where it's flowing. I do think clinicians have access, obviously, to more data than most people, and they are leveraging it very frequently. I'm excited to talk to Dr. King about how to give them more better data to hit more specific, newer goals. But I do think it'd be really interesting to sit down and have at least two conversations. One would be around, like, what would we do with the data if we got it, or even the data that we have? How does it drive measurement and programs and the actual work? And then the other piece would be who has access to that data in such a way that it's being made useful, not just at MDH, but also at the local health departments and any other groups that can and should have access to the data.
Thanks, Craig. Dr. Feldman, thank you very much. I think it's really very great work, and I know a huge amount of effort went into that. We really appreciate you coming to the commission to share that work and to share the setup of the SHA and the SHIP here in Maryland. So much of what we talked about is so relevant to the work of this commission. And I think many of us around the table, if we haven't already, are really interested in diving deep into that SHIP and finding the parallels with the work of this commission. So thank you very much.
Yeah, great job.
So we thank you. We had some really phenomenal speakers today. We've had lots of discussion and thought around the topics that our work groups are addressing. Shane gave a really great kind of insight into what's next and ahead with the commission. I did cut him off before he got to the part about summarizing the regional public listening session, so apologies, Shane. But he did have put together some thoughts from the regional public listening session that are reflected in the slides. So please take some time to review that and stay after the meeting if you'd like to chat with him as well. And I'll take a motion for adjournment. Everybody's ready to adjourn. Oh, I'm sorry, just to make a reminder, thank you, Jason. Our next meeting is that special meeting on November 20th from 10 a.m. to noon. That's virtual only. Please review the draft interim report and provide your comments prior to that meeting as best as possible, because we really need to get to a version that we can approve. Not that we, of course.
The only other aspect of this is if you please look at your calendars now. I need commitment for that meeting, because if we don't have a quorum, then we're not going to be able to fulfill the purpose of the meeting. So be honest, look at the schedule. If you can't make it, then let us know ahead of time, because if we aren't assured a quorum, then we'll have to find time, right? That's, it's a key feature, and we really do want to, meet that December 1st deadline. Just so people like Senator Clarence Brown aren't upset at this. Be there.
All of our, yes, thank you.
But no, the quorum is going to be critical in that meeting.
And again, thank you to Prince George's County Health Department and first my government overall for their amazing hospitality. We really appreciate the technology seemed to work really well today. Thank
Yeah.
you.
Please make it work next time too.
All right, we have a motion to adjourn.
The December meeting, the regular December meeting is gonna be December 5th, Thursday here. So actually, the special board meeting on November 20th. Following that is the December 5th meeting from 2 to 5. So please, you want to see here, let's see your faces. And then, yeah.
Thank you.
Motions, second. Thank you.
Is everybody in favor around the room? I think that's fine. All right, we're gonna go ahead and adjourn and cut the video. Thank you everyone for participating
Thank
today.
you.
Thank you very, very much for all your questions and comments.
Thank you.